public board meeting. It's a meeting in public. People, I think, understand what that means. We've introduced ourselves. We've got 3 apologies, Steve Broomhead, Ian Ashworth and Warren. Just before we kick off the meeting, I just want to say something about today. You will have all noted, as you've been reading through your papers, that there's a very, very heavy agenda. So forgive me when I push people to curtail what they say. So apologies in advance. And for the presenters, you must assume that every board member has read the papers and be really clear on the main issues that you want to highlight around this table. So we all know that format, don't we? And hopefully we'll get through the agenda today in with good grace, as well as being really, really productive. So, any declarations of interest? So I'll move straight into the report of the ICB Chair, and in line with what I've just said, you have been able to see the paper in front of you. I'm just going to make a couple of, one announcement. We have round our table Andrew, just wave. So Andrew's our new partner, one of our new partner members, representing local authorities. I'm really, really pleased to have you around the table, Andrew. So welcome. Just wanted to also I wanted to confirm, and I'm really pleased to say that Erica has been appointed for a further term as a non-executive director. Other than that, you've read the report. Are there any questions or comments? No. Okay. Thank you. Shall we go on to the story? Can we get that up and running ASAP, please?
In January, UK Health Security Agency declared a national incident around measles. Real concerns are seeing increased cases in the West Midlands and in London. And we were concerned about that spreading to other towns and cities such as Cheshire and Merseyside, where some of you had the lowest uptake of measles, mumps and rubella vaccinations in some of our communities. So NHS Cheshire and Merseyside led a multi-agency response really effectively with our partners in local authority public health, our NHS providers, primary care, UK Health Security Agency, and our other screening and immunisation providers as well. As part of that response, we want to make sure we are ready to deal with any infection prevention control issues, but also drive forward the vaccination rates in some of our most at-risk communities. Our primary care teams also part of a national call and recall programme, and they worked wonders creating opportunities for vaccination in local areas and communities, putting on additional clinics at weekends to remove those barriers to access and make it as convenient as possible. Really proud about the whole approach we took in order to remove barriers to the access to the vaccination and get the advice that they need. So, for example, our Live Well bus went into the heart of our communities where we needed it most, in particular Liverpool, South Sefton, Knowsley, supporting some of our underserved communities, ethnic minority communities, homeless, asylum seekers, and delivering MMR vaccinations. And they delivered just over 250 MMR vaccinations during those months to February to now. We also had outpatient clinics from Alderhay, working with our children and young people within Alderhay and promoting measles, mumps and rubella vaccinations there. Our primary care networks were working with local communities in the really low uptake areas to understand the myths and concerns that some of our families and carers may have around the vaccine, and working with them proactively to encourage uptake there too. We were also part of a national community pharmacy pilot as well, contributing to the opportunities to increase access to MMR. And we had our fantastic school-age immunisation services going out to primary and secondary schools, creating the opportunity for our 5 to 25-year-olds to get vaccinated too. And that all contributed to over 14,000 vaccinations in the northwest happening, 7 times more from between January and March last year. That really is a massive way of working together and making a real positive difference.
I have 2 children who are 10 and 14. They both had their MMR vaccine when they were little. The first dose when they were just 1 year old, and the second dose when they were just over 3.5. As a mum, it's my job to protect my children, and by giving them the MMR vaccine, I feel like this has given them the best long-term protection against measles, mumps and rubella. Getting vaccinated also helps those people who can't be vaccinated, so by having the MMR vaccine, we have helped to protect our whole community, people like newborn babies and people with a weakened immune system. I think that it's great that children who have missed their vaccinations might be able to get the MMR vaccine at school. I'm really grateful that my children have had access to a vaccination programme, and it's really reassuring that I can check their records to make sure they're up to date, especially in the latest measles outbreak.
Our communications were based on working with local trusted clinicians and directors of public health, and that also informed the National Childhood Immunisation campaign that was launched. So thank you to everyone who's been involved, and just goes to show what we can do by working in an integrated, joined up way.
It's often that we concentrate on the acutely unwell, and rightly so, but hearing that story about being proactive and protecting our children, it's great. And that's work that this system does really, really well. So, Graham, let's go on to your report.
I will try to comply with your spirit of brevity. So 2 or 3 things I just wanted to highlight for the board today. We're pleased that the new government has already commenced talks with the junior doctors around industrial action. Anything that can be done to stave off further rounds of that is something that we should only welcome and applaud. Secondly, I just wanted to note that general practitioners have taken a ballot for something that is not called industrial action, because of course GPs are not directly employed by the NHS, but they do hold contracts with the NHS. Now, this is therefore being described as collective action. Now, I will just remind people that GPs and Department of Health and NHSE could not reach an agreement on their contract for the year that has already commenced, and therefore the contract was imposed upon them. Now, the contract is complex and difficult, but ostensibly this is an issue about resources. And what was imposed upon the GPs was an uplift on their contract from the previous year of just 1.9%. So I think we accept that GPs are effectively looking to find ways to take collective action to improve their negotiation position with the government in their contract more generally, but specifically around the financial settlement. Now, GPs will not break their contract, and that's a really important point to make. But GPs will consider a range of things, and the BMA have published a list of 9 things that GPs should consider, varying how they work once this period of collective action commences. Now, I'm not going to highlight all 9 of those elements, but I will just pick 2 for indication. So one is they will not cooperate with schemes that are designed to reduce the cost of prescribing. So their argument would be they are not in breach of contract because every patient that needs medication will still get that medication. But what they won't do is they won't participate in the schemes that the ICB has put in place to enable best value to be achieved from that prescribing. So that could have an impact on the overall NHS budget. Another thing that they are saying that they will do is they may restrict the number of appointments per GP per day. Now again, if a patient has an urgent need, the contractual requirement of the GP is they should see that patient with an urgent need, and I believe GPs will do so. But for those patients whom an urgent need could not be determined by whatever form of kind of telephone triage or screening that is taking place, they will direct those patients to other portals. Now, I do not believe GPs are going to direct patients to A&E, But if a GP refuses to see a patient because they've effectively reached their quota for that day or that week, then the chances are we will have more patients presenting at A&E. So again, we quickly hope that this will be solved with the government, but we will put in place those arrangements that similar to what we have for each bout of formal industrial action, where we will stand up our emergency planning responses. We will monitor the situation carefully, and we will look to take whatever contingency action we can if we see pressures emerging in the system in other ways. So we'll watch this one very carefully. We absolutely, as we did with junior doctors and other members of NHS staff, we absolutely respect GPs' rights to take action, but we will not respect their rights to breach their contract in any way, shape or form, and therefore we will monitor the situation very carefully. On that subject, I just wanted to highlight the GP survey. We have had the high-level results for the GP survey. It's probably another month or so before we get them in detail broken down to every individual practice level, but practices have received their own slice of the data. The high level we've received has been at PCN level, and what we can deduce from that is the GP patient survey says in Cheshire and Merseyside you are likely to have slightly better experience of GP services than the England average. But what we can also see from that when measured across PCNs is wide variation. And again, it will be beholden on us working with our places and our place teams to make sure that we support those practices that have had the poorest survey results to improve the quickest. Something in my report this time about our investment in inequalities. Now again, this comes back to the overall financial position of the ICB. Dealing with the challenges of today crowds out our ability to invest in things that will make a difference to health and healthcare in the future. But through our health and care partnership, we have now agreed a modest investment in making sure that we are spending some money on upstream primary prevention, and we're reporting back here that that has now been through the HCP. Priorities are agreed, and a mechanism for some of that money to be spent on a single approach, such as tackling smoking or tackling obesity across the whole patch, but also then the distribution of resources down to place level for decisions to be made in place level in conjunction with place partners on effective primary prevention schemes moving forward. The decision will rest at place level, but we've given them a strong steer towards young people and children's, because that is where we think the best longest term difference can be made. And then finally, it's in a report and we will have plenty of time to reflect on this, but after 37 years service to the NHS, Chris Samosa has announced that she will be stepping back and leaving us at the end of December. We will talk about that nearer the time, but we'll have plenty of opportunities to place our recognition for Chris's service. I have to say I was devastated when she told me the news, but the thing that the board needs to know is we have now commenced the process for full, open and transparent recruitment of a successor to Chris. I'll leave it there, Chair.
Thanks, Graham. Any questions or comments for Graham? Chris?
Yeah, thanks, Graham. And I just wanted to highlight the part in the report about one of the best for diagnostics within Cheshire and Merseyside. So it was pleasing to read, but I also wanted to bring to the board's attention that week commencing the 17th of September this year, Will Patient Safety Week commences with a focus on improving diagnosis for patient safety, with a specific remit about diagnostics, and the slogan that they're using is getting it right and making it safe. So I wanted to share with the board that the focus of the System Quality Group in September will be around the diagnostics that we deliver within the system, but also the areas that we can demonstrate some quality improvement so that we can achieve the push for the 95% that Graham has mentioned within his report. And I'll bring something back in a future Director of Nursing report about the progress that we've made on that.
Thanks, Chris. Ruth?
Thank you. I just thought it might be helpful if we could hear a little bit about the impact of the Microsoft outage last week on the services in NHS Cheshire and Merseyside, whether there are any lessons in terms of business continuity that we need to pick up from that, and also to appreciate the efforts that primary care systems in particular, I think, had to take to make sure that services were maintained as best as possible.
Okay, thanks, Ruth. John, do you want to give a response?
Thanks, Chair. Yes, whether the impacts on services were significant but remediated quite quickly. Just to summarise the source of the incident, you've probably read a lot about this, but essentially one of the biggest cybersecurity firms in the world, their automatic patching of systems, which is done to keep us safe and is highly automated, missed a checking part of the process on one of the patches, and went straight to the memory component of Windows operating systems. So any of our systems that were reliant either directly or on hosted architectures on that immediately were taken down. In our patch, the biggest impact was, as you say, in primary care with EMIS going offline entirely, and in community services and urgent care. We also had significant issues around the allocate system, which is where we plan shift work and allocate resources, and that was equally disruptive in our hospital settings. Great response, I think, both digitally and in terms of EPRR, and to some extent, because EMIS is a nationally contracted and managed system, we were heavily reliant on some of the national conversations. So in terms of recovery, it was a matter of just communicating and assessing risk. In terms of the business continuity and disruption, I think there are a number of lessons to be learned. There's some work to be done with suppliers around offline systems. So in that scenario, really what you need to do is be able to go back to a digital version of the last piece of data. And there were some parts of the system where that didn't happen for a number of reasons. So we'll pick that up in the deep dive, lessons learned. And then a familiarity and a level of comfort with going back to paper. And again, I think in some of our primary care settings, that was second nature. In other areas, probably less well rehearsed. So there's something we need to do collectively around that. And similarly, with some of the acute rostering services, I think some of our trusts were blind around who was due in on the Saturday. On a more strategic level, it has stimulated debate nationally around the move to cloud and the increasing move of all our systems into hosted settings. Offers, in theory, more resilience, but there is a question being debated in a very real way now around how the balance between convergence and the benefits that hosting gives, and actually us having an element of local control. So I think as we pick up the lessons learned, there'll be some collective work around supporting our services in terms of BCP and other digital options. So if EMIS is unavailable, how can you still place a digital order without going through EMIS? That kind of sort of plumbing question. And then just more, I guess, rehearsal and familiarity with BCP. And then I think locally we've described in the CIO group, can we do more to provide our EPRR and operational colleagues with an understanding of how all the systems are joined together so they can understand what the problem is and how to circumnavigate it. So I think there's a big national deep dive and lessons learned. We're going to do a piece with Anthony and colleagues, and we'll collate that regionally. I think although it was a difficult few days, I think it's a helpful prompt, because it won't be the last time this type of incident happens, and I think we need to get better at being prepared to work without our digital systems for a period.
So I suppose that's the technical plumbing bit, as John's described. But I think really it's just a big thank you to our primary care general practice colleagues in particular. We've been in contact with them through our places. We've been talking to the local medical committee representatives, and I think recognise the pressures it put on them, not just the GPs, but the whole primary healthcare team. So just a big thanks. And obviously all the stuff that John's looking at, and obviously Anthony as well, in terms of working over the weekend and all the sort of reviews and analysis of what went wrong and how we can make it better, we'll work with our practices going forward. Just a big thank you, I think.
Good. Well said, Claire. Thank you for that, John. Are we done? Are we happy to move on? Okay. Should we go to the Director of Nursing report?
Thank you. So I will take that the paper has been read, but it's just a couple of areas that I would like to highlight within the report. The first of that being under the heading of all age continuing healthcare. So I wanted to mention this clearly, as all age continuing healthcare is a focus for our recovery priorities, to ensure that we have quality provision and equity of service, but also the financial spend in this particular area. The board will be aware that we commenced a complete review around the target operating model for all age continuing healthcare within the system. The review is currently still in process, but we are now out to consultation with the staff involved in this area of work, which will complete in the third week in August, and with a plan to implement the model proposed and decided upon by the beginning of October. We would expect that following the implementation of this, we will be able to then further develop the metrics around ensuring that we hit all the quality performance targets within all age continuing healthcare. And there's also the further piece of work around the recovery in this particular area. So that is progressing well with the staff. We've done a number of launch sessions, and we're now pulling together some frequently asked questions. So I will bring back further details of that in incoming board meetings. And the second item was around the patient safety strategy. I wanted to share that there's been a review of all system partner patient safety investigation priorities, and this work has supported the consideration now from system-wide opportunities for aligning our quality improvement ambitions. You'll note the report talks about the informing the development of wider patient safety collaboratives, and we're currently working within the system to look at what that initial focus may be on, and looking at some of the data. Potentially a patient safety collaborative may be about the reduction in falls that are recurring within our system. And following the successful implementation of the patient safety incident response framework with our NHS providers, we're now progressing further to how we can implement this a proportionate approach across our primary care and also the care home sector, and we're looking at how we can involve partners in future pilots. And the rest of the report focuses on our statutory responsibilities and situations that have occurred in safeguarding and special educational needs and disabilities, and also covers some of the regulatory activities that has occurred in this period. So in spirit of keeping things to the point, Chair, I'm happy to leave it there and take any questions.
Thanks, Chris. Questions for Chris, Erica, and then Claire?
Sorry if you can hear it. Just a quick question for clarity with my finance head on, please, on all age continuing care. So the review that's still going on, the efficiencies in that, are they looking at this year, so they're in our baked in figures that we are already expecting through the recovery programme, or is this in addition to the efficiencies that we've got earmarked?
Do you want me? Do you want to go first, Claire? Yeah.
So the recovery plan for all age continuing care for this year includes a target which is in line with our current CIP plan, which is assumed to be delivered in the position by the end of the year in order for us to hit our plan. I think the target operating model that is described in the paper isn't necessarily in itself, it is a separate piece of work to the recovery plan. It is very closely aligned, but that's about the way that all the team works across all 9 of our places. And I don't think there's a saving necessarily attached to that. It's just a more effective and efficient way of working, isn't it? But the recovery programme itself, yes, that is assumed within our position.
Just to add to that, Erica, though, obviously with the review and the focus of the target operating model, previously we've used agencies to provide some of this provision around assessing patients and the public. So obviously we would have a team within the ICB that would mean that we weren't using agency, which would bring about a saving there.
Okay. You're welcome. Could I just ask a supplementary on that? Are we on target to hit the projected reduction in spend on CHC in this first quarter? Okay. So if we're not on target, do we think the actions, Chris, that you're putting in place are likely to bring us back to target?
So I'm working closely with Alison Lee, who's the SRO that's leading on the financial recovery part of this, because clearly we have to work closely together to address both finance and the quality provision of this. And so obviously we are establishing what the arrangements are for agreeing packages of care. We're looking to set up a panel about how much agreeing the appropriate spend on the packages of care. So we're working closely together on that, Alison and I, and we can bring further details of that back.
Okay. I think I've got Claire and then Andrew.
Thank you. It wasn't so much a question as just to welcome the sort of development of the patient safety strategy to include primary care. I think we've taken responsibility and we have 2,000 contractors in primary care, so it's really important, and Chris and I have been working on sort of primary care quality for a while now, so I recognise it'll possibly start with general practice, I'm guessing, but I think it's a really welcome move, so thank you.
Andrew?
Thanks, Christine. You'll be very familiar with this message from local government, but clearly in an area where citizens are disproportionately low income, patients that don't qualify for continuing healthcare often fall back on local authority social care provision. So it's vitally important as you take forward that review with any changes to the boundary that is properly assessed alongside local government and the full consequences for local government are taken into account, because it would be inappropriate to make savings against an NHS budget which merely rebound on a very tight local government boundaries.
Yeah, I understand that.
Hilary?
Thanks for the report, Chris. Can I just ask for clarification, safeguarding, Section 8, and we've had significant gaps, haven't we, particularly in the Merseyside area for some length of time. Have we got the assurance processes in place that actually highlight when we're not meeting our statutory functions, and have we got an immediate response for that?
Yeah, so we picked this up through our system oversight board
Right.
that feeds into the Quality and Performance Committee. We've been looking at, obviously it's closely measured, Hilary, and monitored, and we're working with the national team in respect to who can deliver this area of provision. At the moment, it links into shortage of qualified medical professionals, and I think that's the requirement nationally. But I know the safeguarding team nationally are looking at, could we have other clinical professional that could support this, so we wouldn't struggle with the workforce issues.
Yeah.
So we're monitoring that through the Quality and Safety Committee as well, and we're working closely with the providers who we work with for the service level agreement on that.
That's really good, but where we've got specific instances where we are not meeting our statutory duties, have we got the escalation processes in place, and have we got the ability to respond even though we've got vacancies. I suppose that's what the assurance for the board.
Yeah, I think we will take that back through the Quality and Performance
Fabulous.
Committee, Hilary, and give you the level of detail for that.
Great, and like Claire, it's great that you're extending the patient safety processes into social care, because that will give us more integration, because that's where a lot of the incidents, patient safety incidents, happen at the interface. So that's fantastic that you're doing that, so thank you.
Yeah, and we're working quite closely with the Social Care Nursery Advisory Forum that's
Brilliant.
been established, so the councils and we've got an established North West one now, so we'll work closely with social care providers.
That's brilliant, thank you.
Chris, I know I should know the answer to this, but has the board seen a patient safety strategy?
Specifically for the ICB or for the system?
I guess my thought's been prompted by the title, Patient Safety Strategy. I was thinking, have I seen it?
I think each of the organisations have a patient safety strategy, but I haven't got a specific one for the ICB, but we're developing the clinical and care strategy that Rowan's leading on. So there's an element in that clinical and care strategy that focuses around quality and safety.
Could I ask you with Tony's to consider whether the ICB should have a patient safety strategy, and if not, let's clearly understand the rationale for that. Thank you. Claire, should we go on to finance?
Yes, thank you, Chair. The report is quite comprehensive, and I won't go through it, but I'm obviously happy to take any questions at all on any of the content, but I just want to draw out a couple of points. You'll know from our earlier conversation that we have agreed a deficit plan for our system of 150 million by the end of the year. At month 2, we had a deficit of 68.8 million against a planned deficit of 64.5. So we are off plan by 4.3 million, but the bigger risk, the bigger problem is the amount of assumptions that we currently have within the remainder of our plan for the remainder of the year around the efficiencies that we are needing to deliver on. So the profile of our efficiencies within our planned position across all of our organisations is very much profiled towards the end of the year. So whilst we're off track already by 4.3, that hides a much bigger risk towards this sort of the remainder of the year, really. So just the pure maths of that, you can see that in 2 months we've incurred a deficit of almost 50% of our full year deficit plan for the year, which is, just drives home how challenging the remainder of the year is going to be and how important and how dependent we are on the delivery of our cost improvement programmes across all organisations. There is a chart in the paper that describes the profile of the plan on a monthly basis between now and the end of the year. And you can see as well from the analysis that the year-to-date variance at this point, the 4.3 million that I mentioned, is primarily the ICB. Well, it's entirely the ICB at this stage. The ICB's cost improvement programmes are more evenly distributed than providers, but also we are experiencing some real overspends already at this point in the year in complex care packages, so both all-age continuing care and mental health packages, which we've touched upon. So that is, I think, the 2 biggest risks for delivery of our plan this year as a system is achievement of our cost improvement programme, which is ambitious and back-ended, and the second is the current run rate and our continuing healthcare over and above the efficiencies that we are already assuming. You'll know from Graham's report earlier, but also from our conversation before the board started with the public, that we've got we've been identified as one of 10 systems that are subject to a external review and support process, and they were going to be looking at all of our cost improvement programmes. They're going to be looking at CHC, they're going to be looking at our grip and control and financial governance processes across all organisations, with a view to helping and supporting identifying areas where we need to do more to deliver this year's plan. So we see it as a really welcome it was a mandated process, but having said that, we do welcome it. It is important that we are able to shape our system in a way that is financially sustainable into the future to allow us to do some of the bigger investment that we would like to do. That fundamentally getting a grip of our financial position is important, not only to deliver on our statutory duties, but also because it will enable us to provide more sustainable services for our patients into the future. And so there's a lot of detail in here. That's probably all I was going to say at this point, because I'm sure you've got lots of questions, which I'm happy to answer.
Thank you, Claire. So, questions? Neil? Hilary?
Thanks, Claire. Really, really challenging. I suppose just two areas. One is the in-year and the one is the underlying position. The first year position, the in-year position is really challenging, and the CIPs is the big back-ended risk that we've got, and we're already off target. I just wonder, because of the board timing, I don't think the next board meeting is till September. Would it be possible maybe at the development day in August to have an update on month 3 to see where we are, and also where we are on PwC, so we're cited on progress for the in-year period?
Absolutely, yeah, absolutely have to do that, yeah.
In terms of the longer term, there's this thing for me which I always go on about, and you do, which is about the underlying position.
Yeah.
We get to an annualised position where we all have a sigh of relief when we say we can sign off a control total. But that control total sets for most of our trusts a deficit, and we never get to grips with the underlying financial. And we've talked about a 3-year service and financial strategy. And I know it's really difficult to plan in terms of income, inflation and what have you, but are we making progress on a 3-year service and financial strategy so that we can, if we need be, we can make assumptions, but we can understand that with our organisations and our system whether it's doable and what we need to do to support them. And I think we've got to get out of this annual cycle. And while we're working on the in-year position, we've got to be working on that longer-term 3-year cycle. Is that possible, and are we making progress?
Yes, so you'll know from previous conversations at board that we've already mapped out and made a number of assumptions over the next 5 years. So we know what the size of the challenge is. And so we have a long-term financial model that enables us to see the estimated gap over that period of time in the challenge. What we're now obviously focused on is what is it that's going to help us address that gap. And the recovery programme that we've established within the ICB has around about, and I always forget the exact number, I think it's around about 15 programmes of work, of which 5 relate to urgent care, and probably a similar number relate to specific transformation pieces of work in different parts of our localities. So in Liverpool, in Warrington, in Wirral, in Cheshire. And so we are working now through with those programmes what is the size of the prize, if you like, in terms of delivering transformation within each of those areas. If we do things differently in Liverpool across our organisations and in terms of the way patients flow through the system, what is the saving that we could reasonably expect to deliver on the back of that? Same with the urgent care. So we've done some very high-level estimates of how much we currently spend on some of the things that we really don't want to have in our system anyway. So in respect of urgent care, we talked a lot before about how unhappy all of us are with the level of corridor care that we have. That has a very significant cost to it, that if we can solve that, solves not only the patient experience, the staff experience, but also excess costs that we really shouldn't be incurring. So those programmes of work are looking to are underway, but looking to identify what is the efficiency within each of those 5 areas that can be achieved through a better flow through our hospitals. And we've got some high-level estimates of what that could be, but that needs to be owned by those programmes and built up, understanding the metrics that will change. So what does that mean in terms of beds? What does it mean in terms of the numbers of patients in ED? What does it mean on those premium costs that we're currently spending? So yes is the answer. We're progressing that all the time. The point, I think probably your next question will be, at what point can we bring something to the board that shows all of these pieces added together? And I think we certainly can do that I would expect to be able to do that at the next board meeting. You said it is September, so I think we meet fortnightly already on the recovery programmes. We're pushing for us to really start to articulate and scope up the financial benefits. I think by September we should be a lot further forward on that. We can bring an update.
That would be great. We don't expect to have all the answers, but at least some high-level planning assumptions. Yeah. And are providers working on that basis as well for themselves to understand their own organisational futures?
Yes, I'm pretty confident that the majority of providers in our patch will have already mapped out. They will have a rolling, I would expect, and I'm sure will be able to describe how her organisation approaches it, and Jo. But organisations will generally have a long-term financial model that they update on a cyclical basis, and are working through what are the efficiencies and productivity challenges that they're going to be addressing over the longer term. So each year it's not starting from scratch, it's kind of rolling forward on an annual basis. So yeah, I do think that financial strategies will exist within individual organisations.
Should we be asking for that to align it with our own, to make sure that it's coordinated and consistent, and it's something we can work with the trust to understand the challenges they've got, what help they might need or how they might help themselves? I think, would that not be?
Yeah, I mean, certainly last year we had financial recovery plans from each of our organisations that were in deficit at that time, so we could certainly get updates.
I'm thinking about that long-term strategic look for them as well,
yeah,
aligned to ours.
When we developed the long-term financial plan that I brought to board in last winter, it showed the size of the gap. That incorporated within it the recovery plans from our deficit organisations at that time. So yes, we can certainly refresh that for this year.
Thanks, Claire.
Hilary and then Tony.
Thanks, Claire. Great report, as usual. And my question relates to a couple of the reports, actually, and completely behind the recovery programme. It's great the way it's been organised. But when we are embarking on recovery programmes, it's really important to pay attention to our equality impact assessments, all our impact assessments. So I think I'm asking for assurance in relation to, have we got enough capacity and capability in doing these impact assessments? I'd like the board to be reassured about that, well, assured that we have that, so we don't just leave it to one or even two people, and it's not a tick box exercise.
Absolutely.
Thank you.
I'm going to ask
I'd have another question, but
Rowan and Chris to respond to that.
My second, it's a comment, it's a point. I was reading that the NHS Confederation had done a survey over the last month, and for providers of services, and just under a quarter, I think it was around 24% of providers said that they're cutting clinical posts in a response to their cost improvement programmes. And I suppose my reflection is the importance of clinical leadership in this space and the co-ownership of this space, so we don't leave it to our executive that are non-clinical. And so it's a plea that we really do give some room for that voice and co-decision making. That's a reflection, not a question.
I will just come in on that, and then I'll ask colleagues to. I absolutely agree with you. I mean, one of that concept of the unitary board, clinical and operational and financial teams working together is the only way that we will be successful, and all having a joint ownership of the joint priorities. So I'm absolutely with you on that. It's absolutely critical.
So to pick up specifically regarding the clinical approach to this, it is fair to reflect that a lot of our time is spent discussing in forums like this and others the challenge of the money. The reality, I would that certainly Chris and I keep driving for, and I would say is baked into every single project within that recovery plan, is that the opportunity now of 9 places coming together and breaking down those silos is that we can actually plan something that's very much more effective. It's tackling where there's fragility within services and looking to say, how can we reorganise ourselves better so that not only is that service now viable, but usually fragile services are also really expensive because they're being propped up with additional expensive staff and all of that sort of thing. So for example, the entire work stream of unwarranted variation, so I expect variation because we have very different geographies and populations, but I'm not prepared to have unwarranted variation within that, is not only saying, let's make sure that the quality of offering is right, that it is equitable, but indeed, just about everywhere you look, when you start to bring that harmony, you can make it more efficient as well. So there is clinical leadership within every part of the recovery plans, and within each of those work streams are the quality impact assessments that say, so how do we do this, and what's the impact of deciding to do it differently? So I am assured that within every part that is fed up through to the recovery committee, so that we do know it is clinically shaped, informed and led, and that those assessments are completed in every part, so that what we're doing is taking the opportunity to get the offering right for our patients, those that we serve, the staff looking after them, rather than just simply saying we cut cost and that happens to be a clinical post. The patient must always come first.
Thank you. I suppose I would just say further to that than Hilary, it's about ensuring that the clinical voice is heard. So it's about the leadership to support our non-medical leaders as well, nurses, nurse directors and midwifery directors. And so a forum to ensure that, I mean, we meet regularly on them every month, and the focus of the discussion is around how we ensure that we maintain quality and safety, and that from the clinical workforce, our voice is heard in the discussions around recovery. Thank you.
Is that on the same question?
Well, it's sort of, yeah, I mean, it's also about that. In many cases, some of our programmes that are likely to deliver efficiencies can be led by clinicians, and that's the actual, it's clinically led, isn't it, rather than just clinically policed, which I think is really important.
Good. Okay. I am going to suggest, though, on this point, because it's so critical to us, that we hear through the quality committee what level of assurance we should have where we are today in terms of the capability and capacity of the ICB to undertake those impact assessments in a robust way. Tony, if I could look to you to do that for us. I think I've got Tony next.
Yeah, thanks, Raj. I will follow through on that point in discussion with Chris and at the Quality Committee. Claire, you mentioned in section 3 the impact of unachieved efficiencies in the provider position being part of largely the driver for the current position we have. Given that you've got already a 6.5% challenge there, you've pointed out that year-to-date position you've got only, well, not only, but obviously a significant amount of work's been done, 46% of the planned efficiencies, which is also of concern. Do you have clarity from the providers about the reasons for that? Can you monitor it with them? And are there any, at this early stage, any learnings from the providers' feedback?
On the delivery of CIPs? On their in-year delivery of cost improvement programs. I think there was a real range between our providers, and we are working closely with them. So I think we've done a couple of things. One is we collect all the cost improvement programs in quite a lot of detail so that we can review and gain some assurance that things are moving in the right direction in each organisation. But what is more powerful is that peer support and peer learning across, rather than sort of trying to act as a regulator. So over the last couple of months, you probably know, I meet with the finance directors every fortnight on face-to-face, and over the last couple of meetings we've done a session whereby a couple of the finance directors take it in turns each time we meet to go through their cost improvement programme approach, the PMO approach, and some of the detail of the schemes in quite a bit of detail, and they present it to colleagues. And I think what that does is a couple of things. One is it enables sharing of best practice. There's always something from every organisation when they present that I think, that's a good idea. I've not thought of that before. That's a good one. And there is also something about the fact that within our plan, we know that we're asking some organisations this year to drive some significant surpluses within their position, whilst also delivering 5% CIPs. So one of the things that it enables is peer accountability, to show that there's a transparency around the delivery of the efficiencies within all positions. And that is important when we're working in partnership to deliver a collective position. So that's been a helpful process. But I think, the learning is coming out. I think the learning will be multifaceted. I think that's one of the things that PwC will be picking up in their very detailed work as well. Sometimes it's about the capacity, PMO capacity. Sometimes it's about how early you start. So I know Anne's looking at me, so she's in my eye. But I know in MWL, they have and I don't want to speak to Anne, but you have a 3-year rolling programme for your CIPs, don't you? So you don't start for the 1st of April, you kind of, and I'm sure that's also true in Joe's organisation. But sometimes, when you approach it on an annual basis and only start sort of January time for the following year, you kind of lose early ground. That's often a finding. And I think one of the things that we're also encouraging organisations to do is to look at where they're delivering non-recurrent efficiencies and to really challenge themselves that they are non-recurrent, and whether they can convert them to a recurrent saving by, by working with their clinical operational teams to work through how that might be done. So that's another area that we're really focusing on.
Thanks. Just final question from me, it's to Graham. So at month 2, on the ICB's finances, we're behind where we expected to be, where we planned to be. Just give us a flavour, Graham, of what the team's reaction to that has been.
Well, as disclosed, Chair, the principal reason for the variance on the ICB position is continuing healthcare. And, the team's reaction has been one where we have been upscaling our activity around that recovery programme, making sure that we have a full understanding of the drivers of those costs, because it is both in a volume space as well as a price space. And it is making sure that not only is there a central programme, that every single one of our place directors who are effectively hold the delegated budget for that is across and engaged with that process.
Okay, and your level of confidence in year end?
I wouldn't like to put a level of confidence on that now. What I am clear about is there is opportunity, and we will leave no stone unturned to do that. But returning to the question that Andrew asked earlier in the meeting, we have got to be very careful about the unintended consequences of any actions we take. Andrew has highlighted the unintended consequence of shifting cost unknowingly onto social care, but at the same point in time, a proportion of these people have their continuing healthcare assessments while still in hospital. Best practice is to actually make sure that those continuing healthcare assessments happen outside of hospital in a reablement bed or their own home. But what we don't want to do is we don't want to put an action in place that just clogs up our hospitals any further either. So it's complex, it's difficult, it is receiving our best in best attention, but I don't want anybody to think anything other than this is challenging.
Okay, thank you for that. So the paper was here for us to note month 2 and also note the risks. I'm going to pick out 2 things that we've agreed to do subsequent to that. Firstly, at September we will be having some more information on the multi-year strategic outlook of our financial plans, and secondly through the Quality Committee we'll look at the capacity and capability of our organisation to undertake impact assessments appropriately. Move us on to Erica.
So, Finance Committee have had a review. We're here to balance out our time between the here and now and the long-term sustainability. So we have slightly tweaked the meetings. We've gone into monthly meetings, 3rd week in the month, to get the most current information. One of those meetings will be focused very much on an overview of the here and now and more focus regarding the long-term sustainability, so looking at the 3-5-year plan. We will then follow that up with the next meeting that will be focused very much on what's the month's position, what's the recovery plan position and the impact of that, and also what recommendations will be coming through in time from PwC. So that's sort of the new format. I was probably going to reiterate what Claire has said as the highlights, but what I will just say is if you look at page 54 and the chart at 3.6, I think pictures speak louder than words in this one. That just shows you that if we don't move and move quickly with some of these recovery plans, what our run rate would look like. So I think it's a very stark picture on that. Well, I suppose what I wanted to highlight, and see what Claire thinks on these, what I see as the current challenges is we've got to have the right resources within those programmes. So we've talked about clinical people, we've talked about quality people, and we've talked about people with actual project management and administration. We've got to be sure that we've got the right people in the game. We've got to be sure that we're acting as fast as we possibly can. I'm sure that will be one of TWC's reviews. Can we do more and can we do it quicker? The next one is a clear understanding of the figures that we've got in as cash and non-cash efficiencies and when they're going to hit. And I think those will come through. We're more confident of having a clearer picture in September with those. And also the metrics. We're working on getting metrics that will clearly show us that delivery, but I think there's more work that we need to do on that as well. So that's it from me. I don't know if Claire, you agree or whether... Thank you.
Okay, thank you. So some key issues there which will continue to be discussed and debated at Finance Committee. Any questions for Erica? Comments? No, thank you. Anthony, if we could move on to the Integrated Performance Report, please.
Thank you, Chairman. I wasn't going to spend a great deal of time discussing some of the precise metrics around urgent care because I think we've had the opportunity to go through some of that already over the course of this morning. But I was going to offer a level of insight into the development of the recovery programme around urgent care improvement. So, as you're aware from previous conversations, our approach has been one through the 9 places, and we've changed that approach this year, listening predominantly to our providers, and have wrapped locality programmes predominantly around provider footprints. So we have talked a couple of times this morning about the 5 locality programmes. We've been through a process over the past month or two examining the strength of those individual programmes. I can report that they all have consistent governance, they all have consistent aims, they all have consistent scope, and importantly they have consistent ownership across the 3 work streams of all the partners within them. To complement that, we do have 4 at-scale work streams. One is around ambulances, ambulance improvement in its entirety, not just handover, and NWAS are taking the SRO role for developing that programme. We have one around emission avoidance or community services, and the MHLDCS collaborative takes the lead on that through Tony, who's over there. There is a at-scale in-hospital discharge interface work stream, which is led by a gentleman called Dan Grimes, but in conjunction with the DAS, the collection of DASs from the 9 local authorities. And then the 4th one is around oversight and resilience. So some of that is about the visibility of the information, but it's also about the real-time delivery. So some of the stuff that is happening in front of our eyes and how the system coordinates those pressures. and indeed how that system will continue to coordinate pressures in the event of such things like GP collective action, which Graham referred to earlier. The governance, I believe, is strong. It is the first time I've seen a level of planning around urgent care which drives through from intervention to impact and ownership in a much more visible way. And we'll continue to report progress on that through Recovery Committee and the Cheshire and Merseyside UEC Improvement Group. I'll just highlight another couple of things in terms of planned care. We've already talked about the excellent performance on diagnostics. We were the first ICB to achieve a 6-week target objective at the end of this year, and our position remains strong there. Elective, there is the headline objective to achieve 65 weeks, certainly by the year end, but aiming to do that by September. And I think just to offer a level of insight, we've just had some information this week that shows, coupled with quality and finance, that the level of insourcing that individual providers are seeking to manage their capacity constraints has much diminished over the first quarter of this year, which to my eyes is showing just how effective the mutual aid and the use of centralised resources like the Wirral solution has offered to the system. So a great move there. I'll hold there, Chairman. I'm just conscious of using the time to ask questions of myself or other colleagues on any of the matters that's in the paper.
Thanks, Anthony. Hilary.
Thanks, great report. Given our focus on continuing healthcare, and I think the comment that Graham made that we've still got people in hospital waiting to be assessed, I was quite surprised at that. It might be helpful to have the 2 senatorial metrics for continuing healthcare on here. Discharge to assess and time to assessment. I think that would really give us some visibility that would drive our curiosity even further and may help in the recovery programme.
Good suggestion, thank you. Chris?
I was just going to reply to Hilary on that, and that was what I referred to in the early part of my report about bringing the metrics back, so around the 28 days. And
brilliant, and it'd be great if we could have that routinely on
sure.
Yeah, thanks. Thanks.
Any other comments or questions on this? Ruth?
Thank you. Thank you for the report. Obviously, lots to go at still in terms of our quality and performance. I wanted to come back to healthcare-acquired infection. We've given assurance at previous board meetings that plans are being reviewed, and indeed it says the action is all place-based teams are receiving assurance, but we don't seem to be making any inroads into the level of harm through healthcare-acquired infection. So my question is, what else are we going to do? And secondly, is anybody monitoring deaths related to healthcare-acquired infection? Thank you.
Chris,
yeah, thanks, Ruth. I know you've raised this at the previous board meetings, and it is a feature within the Quality and Performance Committee, and I know Tony as chair has asked for a deep dive into hospital-associated infections. Obviously, each of the provider trusts have a Director of Infection Prevention Control and a team that are working on the reduction. Regionally, it's a focused piece of work as well, and also from a national point of view, it isn't specific to our system and region. So we're taking some of the learning that has occurred within the south west of England, who've done a specific collaborative piece of work around the reduction of C. difficile toxin, and some of the learning that's come out of there and the challenges. So there's clearly a cultural change that's required, and not just focusing on the patient in episode, if you like. It's about a change in focus around the whole health and social care workforce, because people living at home. So I mentioned previously in my report around the patient safety work that we're doing. This is clearly an area around patient safety collaborative. So we do receive from each of the places working with the local the providers on this, but I think it's about bringing that together and looking at it across the system, but taking the learning from across the country of where and do something once and do it well.
If I could come back, I would have thought the impact, not just in the harm that's accumulated, but the impact on productivity, delayed long length of stay in hospital, is actually part of a recovery programme as well. because the cost related to this, both in human impact but also in terms of running the NHS, would be substantial.
And
But can somebody answer the question about deaths?
Yes, so
Thank
we
you.
would pick up, ask Rowan, and just to come back on that around, obviously from C. difficile toxin is related to antimicrobial resistance as well. There is a focused piece of work within the recovery around medicines, and we also have an AMR and IPC assurance forum where we work together with all our providers in respect of learning from any deaths that have occurred. We would have that through our serious incidents that come through the PSERF as well. I don't know if Rowan wants to mention about mortality.
So every death in hospital associated with these reportable infections is both investigated, individually discussed and reported, and again through the thematic reviews, if there are particular patterns within any one organisation, that can then be escalated. It's worth just a moment of the context. We live in a world of tension, don't we, with increased levels of frailty and ill health, and a real focus on identifying sepsis very early and intervening very early, at the same time that we are battling with the challenge of hospital-acquired infection associated with lots of antibiotics. So I think our clinical leaders are constantly trying to get that balance absolutely right. It might well be, and these trajectories suggest it to be precisely the case, that we haven't got that balance completely right yet, because we are seeing infections associated with prolonged antibiotic use. So the AMR work in particular is vital, so antimicrobial resistance, and pushing through the quality routes within every trust that those protocols are right, that stop dates on antibiotics are on every form. I know certainly within every trust that I've worked in that patients are individually discussed when this happens, as sadly it can. Thanks.
Okay. Thank you. Chris, I think the discussion that you've just had reinforces the need for a patient safety strategy, so that the ICB clearly understands its role in the system, promoting high standards for patient safety. Any other questions or comments? I've got a couple, if that's okay. I'm just looking at some of the new indicators. Well, firstly, Anthony, I should have said right at the beginning, the way this report is evolving, and especially the exception report, I think it's great. It's really good and informative for us. I was looking at plan care for children under 18, and the fact that we have currently got 1,542 waiting more than 52 weeks. I think we all appreciate how difficult that is. Two questions. One is, what are we doing about it? And secondly, the local trajectory of 1,600, why isn't that zero? Because it shows us as being green, meaning we're on plan, but
Sorry, Chairman, could you just remind me which
it's in the ICB aggregate position, you know, the tartan.
Do you want me to have a go, Anthony?
It's okay. Yeah. So at this point in time, the national operating model is uniform for children and adults, and it's 65 weeks is the target by the year end. And therefore, if we have been doing some work with the provider collaborative to understand, based upon trajectory, specialty by specialty, whether or not we can set ourselves a stretch objective, particularly for paediatrics.
Do we know when that work will conclude?
I would expect within the next couple of months that we can probably nail that down to an objective.
So the same to me, you know, the indicator is green because we are at a lower number than we thought we would be at this point in time to guarantee the 65-week government mandate promise. One of the things that we need to look at is these are only children recognised on an open RTT pathway. Yeah. We have a number of children that are waiting in the community dental service that is not measured through this. So we have a number of pieces of work in progress. As Anthony says, could we run a series of initiatives that actually drive the children's waiting lists down more quickly? And we are working with Older Hay and other partners on doing that. And secondly, can we come up with a programme that will actually drive down the wait for community dental more quickly than we are doing currently? So this is at the kind of forefront of our mind, and I would suggest, Chair, that we take a report back to the Children's Committee to highlight that.
Thank you. Thank you. One further one, and Fiona, you normally answer this question, and it's about health checks. And we can see it's sticky.
So, thank you. Yes, we've talked about health checks before. So this is an annual health check, which GP practices have been doing for quite a long time. And so if a patient has their review in December, it will not then come ready for a re-review until the following December. So you can see that the achievement at the end of so it's measured to the end of the year. So last year's achievement was well above trajectory. I think it was 90-something%, or where is it? And it's 3 point something at the moment, because when this data was done, it was just into the new year. So it's an annual target, not a monthly target.
So if I've understood the data that's in front of me, which is on the ICB aggregate position, it says people with severe mental illness on the GP register receiving
you're talking
a full
about
annual physical health check.
Yeah, so I was talking there about learning disability health checks.
Okay.
The new indicator on severe mental illness on the GP register receiving a full annual physical health check in the previous 12 months, that's new, and that is also an annualised measure. However, you can see previous performance in previous years. It has been one that is not achieved well enough, and one of the reasons that we've put it into the report is to shine a spotlight on it and get more attention on it. But it's an annualised one as well. Just
if I've read the data right, I don't think we can say that because people haven't had their health checks in December coming, they're not included in this information.
No.
It says, that, have you had your health check in the last 12 months? So that says to me 57% of people that have only had their health check in the last 12 months, which feels low. But I don't understand the complexity of doing this. Could we do a bit of a deep dive and understand and report back on what that says? Okay. Any other comments, views? So again, here to note, we've pulled out the fact that we would like to see some sentinel metrics around CHC being incorporated into the regular reporting, and just the two issues around paediatrics and people with severe mental health having their physical health checks. So, Tony, can we go on to?
Thank you, Chair. Just to pick out a couple of the higher level points to make. Chris, in her report, mentioned special education needs and disabilities inspections. There's a rolling programme of inspections, and the committee received a report on, if you like, learning to date on these inspections. The consistent themes that are emerging are the need for stronger partnership working at senior strategic level, and also waiting times for community paediatrics therapies and neurodevelopmental assessments being too long. Those are common features nationally as well as locally in the inspection we've had to date. The significant point accepted by the committee was that quality improvement is only going to be effective if it's a joint undertaking involving parent-carer forums and local authority partners working together. So the collaborative unit is proposing a way forward, and we received a report on that, which is an encouraging step in getting better results for children with special education needs and disabilities. We received a report on end-of-life care, and although the programme has received, quite rightly, credit for the improvements it's made, received an award for joined-up population-based thinking and so on. It did identify significant gaps, and the current performance is significantly below what we're expecting to deliver. It's an extremely challenging area, and the progress made in the presentation, it was very clear that first of all we needed to get our information capture right. It's based on GP systems, and there's a very impressive programme underway to gather all the necessary data to make sure that the right people are recorded correctly on the GP systems. That's our big first step. So again, it's a long way to go, and we'll be returning to that at future quality and performance meetings. Just a quick mention, there's an alert there. The Cheshire East Council have reported a significant drop in safeguarding referrals. At this moment in time, or at least when we received the report, that wasn't understood at all as to why that had been such a big drop-off. The deep dive, I think, is underway, and we'll expect to hear from the improvement board about why that's fallen off. It's just an alert at this moment in time. We don't understand it, but it shows for me the sensitivity of the system that we can spot that and take appropriate action. Thank you, Chair.
Thanks, Tony. Any questions or comments for Tony? No, thank you. Should we go to the report of the ICB Place Directors, Tony and Carl?
Thank you, Chair. Carl and I are here on behalf of the other Place Directors just to give you a bit of an overview of what's happening at Place. The document's there, it's quite a long document, but it just talks about how we're supporting delivery of the ICB's strategic priorities at Place and how we're working alongside our partners to do that. What I would probably just preface what I say with is that all of the Place Directors, in terms of our focus, our absolute focus is just on a number of key areas. So that's around the recovery programs. So each Place Director is an SRO for at least one recovery program. But then secondly, it's around the urgent and emergency care recovery element. And that's not just about hospitals, so that's pre-hospital and working with our local authority colleagues as well. And I know Carl will probably want to just say a bit more about that later on. We've absolutely got on our mind financial recovery, what that means for us in Place and what we do to support the ICB strategic priority there. But then alongside that, we've got a sort of limited number of key priorities alongside those major ones in terms of that we feel are important to maintain in Place to keep the momentum going. So, because I'm conscious of time, we're just going to try and draw out a couple of key things, maybe 2 or 3 key things for to illustrate to colleagues some of the breadth and depth of stuff that's going on in each Place. Just in terms of Place partnership development, I think we've got really quite a strong story to tell in terms of our partnership relationships, and whether that be with our local authority colleagues, other NHS partners, third sector, other agencies such as housing, and how we're working to drive forward those integrated approaches that we all want to see. And that really does underpin the work and many of the initiatives that we're trying to take forward. So within our last round of partnership boards, certainly we've all spoken about our recovery programme at the ICB, what that means, how we put that in context for our Place partners. And you'll see reference throughout the document to the different types of work that's going on that supports our recovery and how we're tackling that together. So, for example, there are references to UEC improvement, but also importantly as well around work around wider determinants. That's already been mentioned today, so some of our work in that space as well. Alongside that, we're also seeing progress around the integration agenda. How we're working locally in Place around our care communities, our integrated neighbourhood development. What does that mean? How we enhance our partnership working with third sector partners, but also how we strengthen our collaboration with our local authority colleagues in that space as well. Just as part of the overall Place update, it's probably worth noting that a number of our local authorities have received notice that they will be subjected to CQC inspections. I know certainly a number of our Place Director colleagues are in active discussions about how we can support our local authority colleagues with that process, and certainly in my place we've already had that discussion, but I know that's going on elsewhere as well. We've spoken quite a bit today about health inequalities and the health inequalities agenda. All of our places are really active in this space, via our health and wellbeing partnerships, wellbeing boards, but also our partnership boards, and just how we just understand and address those real challenges such as fuel poverty, food poverty, victims of domestic violence, etc., and how that impacts on what we're trying to do to improve health outcomes in our place. And there are some really good connections within places around that, around with local authorities in particular, but also our housing colleagues and third sector. So we've had some really good presentations that we've seen in our place boards, for example, around health and housing. And that was done by our Health and Housing, for me, in our last Health and Wellbeing Board. And that really teased out some of the issues and about how we want to work better together to support those improvements in health outcomes. But there are other really good examples of that. So we know that in Liverpool, there is a North Liverpool prototype being developed around data-led multi-agency intervention approach, really supporting those residents in North Liverpool with really multiple and complex needs. And similarly in Knowsley, we know that around the PCN model there, they're developing an asset-based approach to reducing identified health inequalities in the Northwood ward, and that is the ward that has the greatest inequalities in their borough. Alongside all of that, we do have a range of strategic initiatives as well underway. So if I just think to Cheshire East, you know, our place colleagues there are involved in the Sustainable Hospital Services Programme at East Cheshire Trust, but also working on the Healthier Futures Programme in relation to the redevelopment at Leighton Hospital. So that just gives you a sense of how we're working with our acute trust colleagues. Here in Halton, we know that on the Runcorn side of the river, we have our health hub at Runcorn Shopping City, so that's really accessible. It's around how our local residents can access services in a really local place, but it's not just health services. Our community providers are in there, our third sector, our citizens advice, etc., all operating from the same space. And we've got another one that's coming up, working with our local authority in the Runcorn side as well. And of course then, just Carl might want to say a bit about in terms of what the Warrington Place team's doing with Warrington Council and with Warrington Hospital around coordinating the use of land and property, and how they use that space more effectively to deliver the components of the health and wellbeing strategy. So it is a really, you know, we're really trying to join up the dots right across a multiple set of stakeholders, which is quite complex, but you know, that's our challenge, and that's how we're trying to take that forward. Carl, I don't know if you want to say a brief word on any of that.
Magic finger. Thank you. Tony, thank you very much for that. I'll pick up on two of those things. I'll talk about urgent emergency care flow and try and put some flesh on the bones of that, and then I'll pick up your point around the estates work that we're doing across Warrington, across our partners. So in terms of urgent emergency care flow, I think the case has been made really well this morning. Anthony talked about what does the recovery programme look like across Cheshire and Merseyside, and what I wanted to do is talk about what that looks like when we start to look at delivery and changing things in our places. And the first thing to say about that is we have 9 places, but we've set this up on 5 catchments. And if I talk about the bit I know best, and that's the Warrington and Halton catchment. And one of the things that we learned early on was we've been approaching flow. What we like to call that in Warrington is ensuring the people of Warrington are cared for in the optimal care setting. So we try not to talk about cost, we try not to talk about beds, try not to talk about no criteria to reside. They're all really important, but this is about, we know this from surveys that we've done with our people, that this is about ensuring they're in the optimal care setting. And we know from work that we've done that that doesn't always happen. So we've had an organisation called Newton Europe that came in towards the end of last year and did a diagnostics for us. And I think, Graham, you've talked about this before. One of the things that really demonstrated was not all of our people are in the optimal care setting. The majority are, but there's a significant number that aren't. And so the 3 things they looked at was the front door. Now that's not just pre-hospital, that's the front door as well. So the bit we call admissions avoidance. So we know when we did this diagnostics that of all of the people admitted at a given time, 30% of those, so this is over 65s admitted, 30% of those could have been managed in a more optimal care setting. Now that might have been the hospital, so it's not saying they shouldn't have been at A&E. That could be same-day emergency care, that could be frailty assessment unit, or it could be our urgent community response unit, which is outside of the hospital. So that's built our work plan around admission avoidance. And then when we look at processes through the hospital, we know that our length of stay for our population is significantly higher than you would expect, and our no criteria to reside is. And then when we look at optimal discharges, from the work we did, and the work was based on case review, so our clinicians, our practitioners, looking at 600 cases and saying, on an ideal day, this person would have been best served on this course of treatment. Nothing new, using the services that we've already get. And we know from that data, 30% of the people discharged from Warrington and Halton Hospital go on to a care pathway that is greater than what they probably need. We know that's not good for them, and we know that has cost. So these findings have been really helpful, because it's, we talk about Newton Europe, but this is our teams telling us what we could do better with the things we already have. And what we learned from that data was, because we've been taking a place approach, so a work plan in Warrington for flow and a work plan in Halton, we've been getting differentiated results. So some of the work is about levelling up one place to the other, and there's some things that we get differentiated results in Warrington and we do in Halton. So something about Warrington levelling up some things and Halton levelling up those things. And we've learned you have to do that on catchment. Our community providers across both places and our hospital providers across both places. And we talk about end-to-end. So for us, that is VCFSE, that is primary care, that's community services, it's the hospital. It's basically anyone that can, in Warrington and Halton, that can help ensure people are cared for in that optimal care setting. So the way we've set the governance up on that, Anthony talked about the Cheshire and Merseyside governance, but locally we have an executive oversight group that meets half an hour every week to keep the pace on, to do the strategic bit, but keep the pace on. We escalate to that. That's got representation from both councils, the chief execs of both key providers and both place directors. And we ensure the pace is on that. And then we have a work plan and a working group that meets every fortnight. The operational groups meet every week to drive that change. We have started to see some of the fruits of that. So our North Star metric is eradicating corridor care. We are seeing that coming down in a sustained way. That is not where we want to be yet, but we are seeing it moving in the right direction. Our no criteria to reside, that we get a report from the hospital on every day. Partners get that, Tony and I get that. That is coming down in a sustained way. So you can see we are starting to make that difference. It's sustaining that as a challenge and getting to where we want to be. I think that's, Tony, that's all I wanted to say on what that's shaping up like. I know similar is happening across the other 4 catchments. We have the lead directors for the ICB on all 5 of those have a sort of self-help group where we check in every 2 weeks, share the learning, see where we're stuck, see where we might be able to offer some mutual aid. I think that's all I wanted to say on that. And the other one, in terms of, you mentioned our approach to housing and estates. One of the things that we've had for about the last year and a half is what we call a DEG. So it's our estates enabling group, and that comes together with all partners to look at, in terms of provision of health and care, have we got the right physical space? We know that's a rate limiter for us. Have we got any voided space that we could use better? How do we maximise the opportunities around capital as partners? But one of the other things that we do is we look at what's in the Warrington plan in terms of housing. So what is coming over the hill in terms of new properties. So if you go to Lakeside, you will see at the back there's 500 new properties. That has an impact on Warrington. what does that mean for the practices that are nearby? How do we maximise things like Section 106 so we can take the funding and use that to make sure that we have adequate primary care in a wider sense, not just general practice. And that, I think, is bearing fruit for us. I think one of the challenges in the context of what we've talked about being in recovery is what are the things you stop and what are the things you do more of. It feels like that the estates group is still one of those things that you keep doing that. If we want to do more out of a hospital setting, then we need the physical space for that. So we've kept that one up and running. I think that's all I wanted to say on that, Tony.
Excuse me, can I just say most people didn't hear that because you were far away from the mic?
Apologies. Okay. We'll try and capture. Thank you.
Okay.
Tony, Carl, thank you for that. You done? Any questions or comments? Neil?
Yeah, just on page 117, the risk matrix. For F8, which is about cost pressures, for Warrington it's got not applicable, and the cost pressure and the risk scores other for East Cheshire and Cheshire West look quite good. Do they reflect month 2, or they seem quite low to me?
Carl?
Hoping that is a little bit better, isn't it? Sorry, I was too far away before. My apologies for not being heard by the audience. So one of the things that we've been doing is we've been running our place risks across our places, and they've evolved from when we were CCGs. And one of the things that we see is when we bring them together for an aggregate view like this, you can see that there is variation. So one of the things that we've been doing on those key risks, so they are things like around finance, is coming together to I think there will always be some variation in terms of impact and likelihood in our places. I think we will see some difference, but that variation does look quite stark when you bring them together. So if we look at the efficiencies one, we don't have one because we describe the risk slightly different, so it doesn't appear in the top 5 in Warrington. So our associate directors of finance will be working together to have a look at driving out some of that variation if appropriate. Neil, I hope that's answered the question.
Should I just make a comment? Carl, I think it can't be right that there isn't a significant risk around finance for Warrington. We know what Warrington Holton's hospital's issues are. So I'm going to suggest that we need to relook at that table. Is that okay, Neil? Because I think it's a critical point. I've got Ellen and then Joe.
Just to commend this report, and I'm very grateful for the reporting on partnership working. It's really extensive in here, and it's very, very useful. I'm just also observing that perhaps some of that partnership working in other areas and other reports might be worth reflecting on, because it seems very exciting here, and to see that at place, but also in terms of those clusters is really encouraging. So thank you.
Thanks, Helen. Joe?
Just to pick up on the partnership piece, it's I find myself sitting here slightly amazed that these reports don't reference mental health once, given that we're sat around a table for an organisation that has a title Integrated Care Board. That was a good attempt to put me off my line there. So I mean, I just don't think, given that mental health is the single biggest driver of disability in the system, we sit here constantly talking about the financial pressure in the system. It's remarkable that I find myself making these statements.
I don't think we can give any response other than that what Joe has said is absolutely right. Rowan? Oh, sorry, Ruth.
Thank you. Thank you for the comprehensive report. It is encouraging. I should say that I've been to 5 of the 9 partnership place meetings now, and I hope to complete my tour around the area in September. And I have to say, it's really impressive to see how much commitment there is to partnership working. I think that's something that we should be pleased to see evidence of, bearing in mind Joe's comment about mental health being more active and visible there. what also comes across is a real energy around addressing child and family poverty and health inequalities, with evidence of workshops, strategies, discussion and so on. But I'm prompted to say, when do we switch it into the laser focus that you described around people no longer needing to be in hospital, and really turn it into data-driven action? There's lots of nice case studies here, but I don't see the data coming through on impact. And I'm prompted by the report of the National Audit Office yesterday, which says DHSC, NHSC and ICSs need to intensify their efforts to manage current and future demand for healthcare by preventing more serious ill health. And we know there are ways of doing this. In the way that we do it with hospital and healthcare, we know we can do it in partnership, that the data-driven approach can work. I was really pleased to hear Tony's comment about North Liverpool data-driven approach with partners. So I'd like to see these reports sharpened up now into proper work programmes with data-driven results coming through on the prevention of ill health. I know the local authorities are busy working on it. I met with the Directors of Public Health last Friday, who are developing a concerted effort to tackle child poverty impacts. I think that we've a real opportunity now to put the same approaches into working in partnership with our colleagues. The energy is clearly there to do this, and I just encourage us as the NHS partner to really step up. Thank you.
Thanks, Ruth. Does anybody else know? So let me just sum up. Firstly, thank you, Tony, Carl, for the presentation. Some really, really rich information. And we've heard from colleagues how optimistic and buoyed up we are by it around your partnership working. That's great. But we've just heard a really important challenge. Where's the data that shows that we're having the desired outcomes? The Ruth's point, really, really important in the future with your colleagues. Let's see those metrics come through. Joe made the point about mental health. We must be talking more and seeing more about outcomes for mental health. And finally, let's get that risk matrix into order. It needs to be consistent with the corporate risk registers, and I think that's just a matter of tidying up, hopefully. We're happy to move on? Yeah, thank you. Should we go on to highlight reports of the Audit Committee, Neil?
Yes, just briefly, Chair. With the Board aware, this was mainly to do with the close of last year's accounts and the audit opinion, and are putting in place this year's plans.
Thanks, Neil. People comfortable with that? It's there for assurance? Yep, we've got that assurance. Tony, Remcom.
Thank you, Chair. Just to pick up 2 points as a theme in the advice section. We heard from the Chief People Officer a recommendation that individuals who are in clinical roles would move towards an employed model rather than the current complex model inherited from CCGs. That was welcomed. And to continue the theme, one of the other inheritances for the ICB are the roles in pharmacy, optometry and dentistry, which are extremely complex and very varied. We've agreed an extension of those contracts, but with a view to actually bringing about a standardised version of this, which would be a considerable step forward. So thanks to Chris for that work. Thank you.
Thank you, Tony. Any questions or comments? It's giving us some assurance. Chris, young people.
Yeah, thank you. So just a couple of things to note that we held the last Children and Young Persons Committee in the Warrington Youth Zone, which started the committee with a tour by some of the youth leaders, which was a great facility, and it was really pleasing to note some of the activities that children and young people within that area have access to. Some of the areas we focused on the committee was the development of the Lundy model for child participation, which is the framework to help ensure that young people are given the opportunity to express and heard their voices. We also had a discussion about the development of a young children and young persons summit. And then there was also the consolidated single line of sight report that's being developed, which outlines the work undertaken across multiple agencies across the system, working with and for the benefit of children and young people.
Thanks, Chris. Any comments, questions? Just happy to receive that assurance. Hilary?
Thank you. Minutes as read. Thanks, Fiona, for explaining the what a draft case for change is. We still have a couple of engagement events to complete. And just a bit of assurance, we had a conversation, a deep conversation actually, about inequalities. And we're going to do some more deep dives into, so we can get some comparative data in terms of what does that mean for this geographical patch, knowing the national evidence and what research is telling us. Pleased that we got the funding for our lay members, which will become colleagues, and we had a discussion about the process for recruiting those and to make sure we make every effort to get some diversity in that cohort of people. Other than that, it's here for endorsement.
Thank you. Questions or comments? I'll endorse that. Thank you, Hilary. Claire, Speccom.
Thank you. This is the first Chair's report of the North West Specialised Commissioning Committee, which is a joint committee between ourselves, Greater Manchester and Lancashire South Cumbria, ICBs, since we took on responsibility for 59 delegated services in April this year. So the joint committee considers those services that we commission jointly, and Cheshire and Merseyside does have a specialised commissioning operational group which has oversight for those services that affect our population only. So you can see there's one item for alert, the rest are for to advise and inform. We've agreed that the financial aspects of the specialised services budget will be reported through Finance Committee, and quality and performance issues through Q&P. So I think it's important to note that. And just saying, over the next few months, we'll be working with the other two ICBs on preparing for a further 25 services that we'll be taking on delegated responsibility for from next April. Thank you.
Thank you, Claire. Any questions or comments? Just one from me. It was an understanding, just very high level, about when do you think we're going to start to progress in terms of looking at the opportunities that delegation has presented to us in terms of our local region, our region, Cheshire and Merseyside's priorities?
We're doing that now.
Okay.
We have 4 priority areas that we're looking at, sort of more integrated end-to-end approach to commissioning, but that's absolutely the whole priority and the reason behind this delegation. But we have 4 priority services. I can't remember the top of my head. I'm sure Fiona will be able to remind us, but we are working on those already.
So we'll see that in subsequent meetings.
Yeah.
Thank you. Comfortable. And finally, the HCP, what you have, the 2 vice chairs of the HCP here, Alan and myself. You can see the detail of the report in front of you. I wanted to highlight the health and equalities funding. That was a very active, good discussion that we had at the HCP in terms of identifying the priorities where we could spend that money in an effective way, and also some of the challenges that were remaining. Ellen, anything you wanted to pick out? Happy to take any questions, comments on this. No? Okay, that's again there for information assurance. So we're at comfort break. I'm 2 minutes over, so not too bad this morning so far. Let's get back into the room at 11:25. Thank you. There is a new agenda, but the pack doesn't reflect the order of the agenda. So Anna, I think we're hearing from you next about the collaborative.
Yes, thank you, Raj. So this presentation is given on behalf of the Cheshire and Merseyside Acute and Specialist Trust Provider Collaborative, otherwise known as CMAST, and as well as my role in my own trust, I also lead all the acute and specialist trust providers across Cheshire and Merseyside in terms of the collaborative efforts to deal with some of the challenges that we face. So these are our programmes that we're focused on. Our priorities are clinical improvement and transformation, sustainability and value. And to that end, we have 4 programmes of work, one on diagnostics, elective recovery and transformation, clinical pathways and efficiency at scale. There's a little note at the bottom there saying we support the urgent and emergency care improvement work, but don't lead that work, we just participate and support that work programme. So our 4 work streams are each led by a senior responsible officer, and they are someone who is a trust chief exec from our membership. So just to start with, I'm just going to run through very quickly some of our achievements in 23-24. So in diagnostics, and somebody mentioned it before, we were the first ICB to achieve the 6-week faster diagnostic standard. Our community diagnostic centres delivered 279,000 additional tests, which represented 15% of all the CDC activity in the entire NHS. So we've made a real success of the community diagnostic centres. We secured 34.4 million in additional revenue to pay for that activity. And we've got double-digit increases in most diagnostic modalities, with an aggregate of 21% more diagnostic tests performed across Cheshire and Merseyside compared to 1920. The trust boards of all of the acute providers have approved a single unified laboratory information management system, and that means it enables trust to share pathology results, so blood test results, etc., across the whole patch, so people aren't subjected to duplicate testing. So if you have something done in one hospital, the other hospital you might attend a week later will know about those results. So it also gives us a platform for greater opportunity for service rationalisation, where we might do the interpretation of blood tests and things in certain places for certain types of tests. And that's for the future. In terms of elective recovery, we've reduced over 200,000 long-waited patients in the past year. We facilitated over 9,000 mutual aid moves. That's patients being moved from one hospital on our patch to another in order to equalise waiting times across Cheshire and Merseyside. We've done loads of work on improving theatre productivity, and all the talk we've had today about the need to be more productive and more efficient. So we've done that. So we've set up a theatre academy, and we've trained 50 staff in how to run an operating theatre most efficiently and get full utilisation of capacity. We've also done a lot of work on risk stratification and rehabilitation of patients who are undergoing surgery, and with that has reduced the average length of stay by about 2.5 days for our high-risk patients. Clinical Pathways programme. We've secured £1 million for a dermatology artificial intelligence system that will enable us to read the scans faster. And obviously that's going to be rolled out carefully and making sure it's safely, but all of our dermatologists on the patch have signed up to participate in that programme. We've secured an iCare Accelerator bid funding, so there's a single point of access currently being piloted in 5 places for ophthalmology referrals to secondary care. That went live earlier this month, but did indeed go live, and that's just to make sure the same criteria are being applied in terms of ophthalmic referrals across the patch. We've also bid for glaucoma monitoring to be undertaken in the lower risk patients in the community so that it frees up spaces in secondary care for the more high risk patients. And in trauma orthopaedics, we've got a 2-day reduction in length of stay, which is massive when you think of how many patients this involves. For fractured neck of femur, knee arthroplasty, also reduced from 3.8 to 2.9. That's knee replacement. The efficiency at scale programme, really this only really kicked off in Q2, fully fledged. We finally got the staff in place. So procurement to scale saved 3.9 million during the course of the year, and that's largely within the trust CIP plans, the individual trusts. Also supported the medical medicines optimisation programme, saving 18.5 million, rise to 25 million with a Pixaban, and all the eligible trusts signed up to a national energy contract which will deliver an £8 million saving from next year onwards. So that's a kind of quick whistle-stop tour of what we achieved last year. So going forward, we've got plans against each of our work streams again, and I won't go into all the detail, but the smaller boxes have got the detail of what we're setting out to achieve within each of them. But basically for diagnostics, obviously reduce waiting times, reduce inappropriate demand, digitise and innovate, increase capacity and access, maximise productivity and secure income to support all of these things so that we can actually get external income to pay for all of the additional tests that we've been able to deliver. So, very focused, very tight programme, exactly clear about when we say we're going to improve things, by how much and by when, is all part and parcel of the forward plan that we've produced. So for 24-25, we've managed to get almost 28 million capital, and what we're doing with that is a cardiac CT scanner for within Liverpool, finishing off the community diagnostic centres in Halton East Cheshire, and for the LIMS system that I mentioned before for pathology. And we've got £58.2 million in revenue, which is mainly due to, if we do more tests, we can access more income. So again, all a good thing to do, because it not only is it great for the patients, it helps the financial position as well. Moving on to elective recovery and what the plans are there. So, been some mentions today of reducing long waits. We've maintained a 0, 78 and 104-week position. The big target now is to eliminate all 65-week waits by September, and unless something goes dramatically wrong, I see no reason why we won't achieve that by September. The mathematics of the plan entirely stack up. We're clearing the waiting list fast enough to achieve that by September. We're also doing a big validation programme so that 85% of all patients who waited over 12 weeks will be validated to make sure the condition hasn't changed or there's some need for something different to happen. One of our key focuses is on reducing variation between providers, so increasing the utilisation of the elective hub theatres. We've done really a lot of work on that just lately, particularly around the site at the Wirral acute site at Clatterbridge, where we've massively increased the utilisation there over even the last few weeks. We're looking closely at what we can do to reduce outpatient follow-ups to free up time to see new outpatients. And this reference, again, there was a reference before to what we've done a lot of work on trying to reduce the reliance on capacity-related insourcing and outsourcing. And obviously, again, that is a big money saver if that can be achieved whilst not in any way impairing the capacity we can provide. And then improving productivity and efficiency. Obviously, we haven't stopped doing that just because we've gone into a new year. So, but some of the focuses for this year: increased advice and guidance. That's to really avoid admission, or avoid referral. So, giving GPs advice on what else they might do rather than send a referral. Increase patient-initiated follow-up, so patients are given the opportunity for a follow-up if they want one, but don't have to have one if it's not necessary. And a big one is to achieve 85% theatre utilisation for all trusts, and that would deliver 9,000 additional cases just by doing that on its own. And for anyone who's wondering why it's only 85%, you do have to clean the theatres in between each case. I would like you to know that we do that. So you can't ever get to 100% because you'll always have that time to clean the theatres up between the cases, which is absolutely the right thing to do. So again, this is the plan for going forward. So focuses are going to be on PTLs and waiting lists, theatre efficiency, doing better things in outpatients to get more new patients through. We have a whole health inequalities programme going as well to ensure that that's always at the forefront of our attention. HVLC means high volume, low complexity pathways, so making sure we're doing all the things as day cases that could be done as day cases and taking that variation in that. Using our elective hubs to the absolute greatest extent that we can, wherever patients are from. So patients from all over Cheshire and Merseyside can use the likes of the Clatterbridge hub. And then the independent sector efficiency, so using it where we need to use it, but making sure we get the best prices and we don't all individually contract. So we've now, CMAS has now taken over that for all of the trusts on the patch so that we've got some coming together of plans around that. And we know where our own capacity is and we can direct patients, trusts to that if that's necessary. The clinical pathways programme, so there's a line at the bottom there that says why did you get chosen to be one of the intensive support type clinical pathways? It's because of a mismatch of supply and demand, a fragility of services where we haven't got the workforce we need to deliver the services we need to deliver, where we've got the biggest best practice opportunities, where we know there's big variation between different trusts and that's been measured and identified, where we've got dysfunctional pathways, where there's too many steps in it and we could rationalise it, and making sure we've got equality of access, experience and outcomes. So when we look at all of those things, we chose some specialties that we felt most needed to be given up because we can't look at everything. So cardiology, ENT, gynecology, ophthalmology and dermatology are the specialties that are the current focus of our greatest amount of attention in terms of trying to make the better. And I mentioned the AI bids for dermatology and the things we're doing in ophthalmology before. We've got some really, really good clinical engagement, absolutely first-rate clinical engagement. And so there's a lot of specialties who are just kind of getting on and doing their own thing and quite, without us having to kind of push them or cajole them to get together and talk about these issues. They're doing it quite actively and appropriately. So general surgery, the perioperative stuff that's going on, musculoskeletal, urology, trauma orthopedics and children and young people. We've got very active clinical networks that are doing a lot of good work to improve things without necessarily being part of our formal programmes. And then the efficiency at scale work stream, it's got a whole load of things obviously playing very closely into some of those financial issues that we've talked about a few times today. But at the moment, focusing on the finance work stream of create a single ledger across the ICB, HR, legal, a lot of money spent on legal, that could be reduced if we did it together. Medicines management, big issue. Procurement savings, we've made quite a lot, but there's more to be made. And the risk and governance. So, again, and underpinning all this is digital things. So making sure we are as automated as it's appropriate to be. And we never lose sight of the fact that we have to keep our eye on the quality side of things. I'll come to that in a minute again. So the key work streams so far, medicines optimisation with the high cost drug savings, quite big figures in these. These are the 24/5 target figures. So it's got 37.2, but there's an awful lot of schemes there that we didn't want to put a figure to because we haven't got to the point of deciding how big that figure should be. But, given the size of our control total that we've got, making a big contribution to trying to reduce costs to the system through means that don't affect patient quality at all, may even improve it. And then I just wanted to talk about, just for 1 minute, some of the things that kind of are a bit under the radar that you wouldn't think we were dealing with, but we are. So because we're doing a lot of benchmarking about everything, especially with the efficiency at scale programme, we're like comparing everything with everything. And some of the things we've, I've just pulled out a few kind of fairly random things. But so the black bars on these charts are Cheshire and Merseyside. The grey bars are Greater Manchester and Lancashire, South Cumbria, and the blue bars are everybody else. So that shows, the first chart shows that Cheshire and Merseyside has got the 5th highest cost for the size of its population for primary care prescribing. So of all of the ICBs, we're the 5th highest. That's just a statistical fact. The second chart shows that part and parcel of that high spend is that we've got the highest number of patients in the whole country who are prescribed 20 or more medicines. And the third graph shows that we're the 3rd highest in the country for the bed days per 100,000, so based on our size, following falls which result in fractures. So if we could avoid more of those falls, these are falls take place in the community, then you can see that would have a massive effect on the use of bed days, but most importantly, the biggest effect on keeping our residents safe from the harm that we all know results from some of these falls and the life-changing circumstances, and indeed aftercare. And then just again, came up before, we were talking about infection control before, weren't we? And so we've got a work stream on infection control because we've got a quality lead that makes sure all of our work programmes, do quality impact assessments. And this is another one of those where isn't interesting when you look at where we rank. So the average cost, again, per 100 million, so on our size, the average cost in Cheshire and Merseyside was 123,000 per 100 million, compared to the median of 89,000 per 100 million. So we spend more on infection control than the average ICB. And yet we've got one of the highest levels of hospital-acquired C. difficile. So it's like, how come we're spending more money than most, but we're getting more infections than most? So what this person is doing is looking into that, trying to work out why it is that we're spending more and yet we've still got more infections. Now, a lot of this stuff will be explained by deprivation. And there's no question about, we have got a very highly deprived population. But I don't think it's right that we stop at that. We just should say, is there anything you can do, despite the deprivation, that might improve our position, because it would, reduce harm, reduce pressure on beds and reduce spend if we could tackle some of these things. So, thanks for listening. I'm not really asking the board for anything other than endorsements that were really, on the right things, and it fits in with, the board's strategy in terms of what the board thinks is important, as well as what we, as the provider community, think are important.
Thank you, Anne. Any questions or comments? Naomi? Put the hand up somewhere over there. Ellen, sorry.
Thank you. It was more just a comment, really, that the benefits that we're seeing from CMAST's work, it has a much bigger impact on the wider NHS system as well. Particularly looking at general practice. When you have patients who are being seen quicker for their outpatient appointments, it means that then there are fewer follow-up appointments in primary care. In particular, I hadn't realised that the ability to now see blood results across the whole system was actually from CMAST, because that again has had a massive impact on general practice. It means that we're not repeating results within general practice, and so and ultimately this has a positive effect on patient experience and on patient care. So it was just to acknowledge that, really, and say, certainly from a general practice perspective, there's been real positives that we've seen from this as well. So thank you.
Thanks, Naomi. Rowan?
Thank you. So I end up having touch points across an awful lot of the programmes there, but just to pull out in particular the dermatology piece close to my heart as a skin cancer surgeon. I think AI brings two instinctive sensations, one of excitement at the possibility of working very much smarter, but also a risk of discomfort of, what does that mean in terms of safety and all the rest of it. What's particularly exciting about this is the AI bit itself, the product, has already been through all of the safety hoops and is registered as a Class 2 medical device by the MHRA. And the opportunity that we are really exploiting is to say, how does this mean we can get the right patient in front of the right clinician more reliably, shorten the pathway that supports fragile services like dermatology? And I think it absolutely extols the virtue where technology directly impacts the outcomes of all of our patients. So I'm really pleased to see that. Ways of working that were almost lost, see and treat clinics, potentially come back now because we're putting exactly the right patients in front of a surgeon very, very early on in the pathway. So really pleased to see how that's progressing. Thank you.
Thanks, Rowan. Alan?
Just on the issue of falls, I wonder if there is some work some partnership work that we might do with the voluntary community, faith and social enterprise sector around the falls work. I suspect you're already doing that, but I wonder if that also might be a way of us test casing some of the way that we might interrogate the veracity of that work. So thinking about metrics and data, it might just be a useful project for us to drill into in terms of the way that we might work in a partnership.
Yeah, it's a kind of, I'm looking, Tony sitting next to me as place director, you know, that this is something, I mean, we haven't done any work on this as CMAST, it was just that we've been pulling out all of the comparative figures just to, because it's a good thing to do, to see, you know, just where we sit in league tables for things. And, you know, because we've got a deprived population, you know, we're always going to be somewhere, and we're big, you know. That's why doing it per 100,000 of population or money or whatever it is useful, because otherwise we're always the top of everything just because we're one of the biggest. But I do think from the point of view of the consequence of falls, when you think, you know, the trauma for the patients, the hospital stay, then, you know, often people come really deconditioned and then they probably need a care package or even residential care. You know, what the consequences of, if you just nip that in the bud, that would be a massive benefit, not just from the point of view of the well-being of our population, but also because it would, you know, take out of, you know, all the negative consequences that go with it from a service provision point of view and a financial point of view. That would be, you know, it's like, what's not to like? So I think it is something that'd be good if we think about, you know, how we could work together with our places, and certainly CMAST are happy to put to play into that. If there's things we can do, that would help inform what might be the best way we could reduce the number of falls taking place, because other ICBs are doing it better than we are. So what are they doing that we're not, you know?
Thanks, Alan. I'm going to bring in Rowan then Graham.
Yeah, just to respond to that. So colleagues will know we have the Data into Action programme, and in amongst the two big priorities there, as well as our patients living complex lives, is frailty and falls, because often the fall is the end product of people struggling with their frailty. So now, with our ability to far better predict and identify who's at high risk in this space, it's then about exactly bringing forward the right community response, because it may well not be a medical response that is required, but the wraparound within people's neighbourhoods and communities. So that is being actively constructed. We do have our voluntary community and faith sector colleagues involved. Really happy to brief you further on that outside of this and keep you close to it, because absolutely what a difference you make when we prevent people ending up in hospital in the first place. Thanks.
Thank you, Rowan. Any other questions or comments? Ruth?
Thank you. Very impressive, fantastic contribution to improving care in Cheshire and Merseyside. You won't be surprised to say, I just wanted to ask a little bit more about the health inequalities element of the work. And I was really interested to see that you've developed a dashboards at trust level to help with the elective programme to take into account health inequalities. And I wanted to ask, what metrics are you using to show progress that you are reducing the health inequality gap around that? And is that something we could actually surface more at the ICB level in terms of us being able to understand that we are making a difference in that area?
I'm going to let Rowan answer that, because he's really been the big active player in all of this. So, Rowan?
Yeah, thank you. So it mattered me to me a huge amount, again, as a surgeon, that we think about our highest risk patients on the waiting list. So I can find them because we've got the data as to the comorbidities these patients live with. We've then cross-referenced it with health inequalities data around deprivation, and indeed 40% of our highest risk patients come from the 20% most deprived households in Cheshire and Merseyside. The work that we've pioneered out of Wiston meant that these high-risk patients were being prioritised, and in particular through the summer, when they were likely to be at their best. They're also being prioritised for a prehabilitation offering that has shown that we've almost eradicated the high risk of chest infection these patients lived with, taken 2 days off the length of stay, and halved their cardiovascular complications associated with surgery because we've done the pulmonary prehabilitation. So not only did we eat through that part of the waiting list early on, but we've shown significant improvement in the outcome for those patients. Those data are now flowing from every trust. And the work that now goes on is to how that prehabilitation offering is embedded into a business as usual approach in every trust. I've got the next 4 or 5 trusts that are now coming on board at pace, and I would like to see this everywhere. But it does, the fact we can find these people and make the difference is exactly the right thing to be doing.
Thank you. Can I ask that we look at how we can actually monitor that we are doing this really well and that we are changing people's outcomes? I think this is really encouraging. But I don't think we have much visibility in the data we look at. We only look at process. We don't look at the results in terms of outcomes.
I was going to ask the same thing, Rowan, through you. Could you think of a report that regularly comes to this board that looks at that information? I recently saw the Cancer Alliance's report on this, where they were showing reductions in most deprived versus the least deprived in terms of early detection of cancer. It's really important for us to see. Could we have a look at this?
I'd be delighted to bring that back here because we're also managing to get this into peer-reviewed publications nationally. So delighted. Thank you.
Thank you. Fiona?
Thank you, Chair. It was just to provide some reassurance on the polypharmacy that because we are very much aware of our top-bottom position nationally, and there is a programme of work around polypharmacy within the ICB's medicines management team that is aligned to the national polypharmacy programme. It forms part of our recovery programme because there are significant financial benefits to reducing polypharmacy, not just the drug costs, but polypharmacy is a significant driver of hospital admissions, and therefore if we address polypharmacy we will make savings there. But more importantly, it improves patient outcomes when we address polypharmacy. Happy to bring something back at some point with Suzanne Lynch, our Chief Pharmacist, who's leading that work.
Good. Well, that'll be really useful, Fiona. Thank you. And thank you very much for your presentation, and thank you for the leadership that you've shown to CMAS. I think we've seen some incredible results over recent years in terms of the right thing for patients and how staff are buoyed up by it as well, because it's demonstrable. Thank you very much for that. Joe, I think we're handing over to you, and we're asking Isla and Tony to come. Okay. Isla, over to you.
Hello, everybody. Apologies, I'm sitting in the back to everybody there. Isla Wilson, I'm the chair at Cheshire and Merseyside Partnership, but I also chair the Mental Health, Learning Disabilities and Community Service Provider Collaborative, which has a very snappy title, I'm sure you'll agree. We have some slides to take you through, similar to the topics we've just talked about. This will look at the achievements in the collaborative for the previous year. It will also look at the work plan for the year ahead. I think what you'll see is it actually dovetails quite nicely. So you'll see as we get into our presentation, for example, some data around falls prevention in the community, outlining the scale of the opportunity there if we are able to focus more attention and resource on that. So, Anne has presented figures about the impact that has on acutes, but Rowan has rightly pointed out that the preventative work for that happens outside that realm in the community. So we'll talk through some of those links. The body that I chair, that's relatively new. As the chair of that, I meet regularly with Joe, who chairs CMAST, just to look at those links and to make sure that we are starting to hook that stuff in more closely. You'll see some of the progress for the previous year, and really the other thing you'll see in our slides is an attempt to amplify the case and the value proposition for some of the work that we would like to see happen in that collaborative. So we will be asking for you to endorse the work plan, but as you'd expect from a non-executive chair, we're also going to highlight some of the risks. And so in endorsing the plan, we want you to do that in full awareness of some of the risks of where we are in this in terms of decisions that have been made and decisions that could be made, so that we're all going into this with a sort of shared agreement about what is and isn't possible, given the decisions that we've made about resources, work plans, etc. That said, what I hope you'll see is some really good progress on a number of things that are really important. We'll talk about the virtual wards and the kind of the ups and downs of that programme. But we'll also be talking about things like the community data. So you may all be aware, but there isn't really the same national framework for data in some of the services that sit under this collab as there have been for acutes. So the fact that we are now able to compare across places and across services and see where that variation exists is, I think, a really impressive piece of work from the team. It really allows us to do some of that data-driven decision-making that we've talked about today. Joe, I'll hand over to you.
Thank you very much, Isla. So looking at last year's work plan, I'm going to pay a bit of attention to the first couple of bullet points first. So the access to care issues and community urgent care and so on, and we've made really significant progress against this. But to go back to one of the points that Isla made, I think it's fair to say when we started to really unpick this, it was clear that we either had no data or the data we had suffered significant data quality variations, or that the sort of data standard and definition that is used around these data sets, if you had 3 people in a room, there would be 6 or 7 different definitions. It was that sort of level of variation. So when we first started to look at, well, what are the waiting times inside some of our community services, it was effectively impossible to create a comparative context right across Cheshire and Merseyside. So that sort of took us back to position 0, and Tony and colleagues have done an enormous piece of work to not only describe the data that we need to collect, but also then to standardise the data that we currently do have. And we have now a really reliable community data set and dashboard. And the importance about that being, I emphasise reliable, is when we look in dashboards and we look at trajectories, we can often end up making really, really the wrong decision about what we need to do to correct the trajectory, because actually it's not a real thing, it's a data abrogation. And I would say now, against our waiting times position in Cheshire and Merseyside, we're really clear that it's accurate, and therefore the decisions we make are likely to be sound and good ones in terms of correction. And I would say across a number of our providers in Cheshire and Merseyside now on community waiting times, I would be happy to predict that a number of our services will be in the top 3 or 4 in the country in the next 6 months or so. And that's because we've got a real grip on the data at this stage. I think too, it has really drawn out for us something that those of you who've been around the development of this collaborative for a long time already know, that commissioning of these services has been lumpy, let's say, to say the least. So where we see services in providers and at place, what we can see is not the same amount of money spent per head of population or against any identified measure of need. So what we've been doing is trying to work out and subtract what issues are due to variability in the commissioning against standards, and what issues lie at the foot of provider variation or provider choice. And I think I'll show some data in a minute that shows actually we're starting to really pick that sort of problem apart. We are, because of, I think, the emerging nature of the sort of priorities across the ICB, starting to think about some of our programs that, like our workforce program, which we think is really important, workforce transformation, but it won't be necessarily a collaborative venture. It will be an inter-provider venture. It's a subtle difference, but it's really, really important, because sometimes we've got such different problems because of the nature of the variation that we'll handle workforce transformation issues, but outside of the collaborative, but not necessarily not in the view of the collaborative. Mental health is one of the programs that we've really focused very, very hard on, because what's different from the mental health programs, distinct from the physical community programs, is although data isn't brilliant in mental health, it's an order of magnitude still different to community services. Still an order of magnitude at least behind where acute care is, but we are where we are. But we've done some significant work on mental health, as you can see. And I'll just go through one or two of the headline figures, but a 79% increase in delivery of physical health checks to people with SMI. Not just through the use of the annual health check, but basically using the principle of every contact counts. So particularly the two mental health trusts using their physical health internal capability to pick up patients on every contact and continue to, and I think actually this is a really important thing for us to begin to think about, because while the annual health check is great, we've talked before about the risks of an annualized health check sort of issue. So I think that's a significant change. 82% increase of people assessing community mental health services. This is in part our equivalent of corridor care. We don't have in mental health physical structures the ability to keep people on corridors. So in effect, people who would have been admitted to hospital become really high-risk community patients. We've seen an increase in that, but actually what we've also seen, I think, is a real distinct improvement in the quality of our community services, in our ability to handle sets of patients who are really, really much more complex, but are being managed to a good level of quality in the community. I think this 194%, it doesn't refer to the perinatal piece, I think. I think it refers to access to our crisis line, mental health crisis line. I don't have the full figure for Cheshire and Merseyside, but I know for my own trust, we handle 14,000 calls every month from patients who are in mental health crisis, or if it's not mental health crisis, are significantly concerned about their well-being and welfare as to call in to the trust. That's a huge number of calls to handle. And inside that story, both mental health organisations in Cheshire and Merseyside are now starting to use generative AI and really, really sophisticated telephony to make sure that we don't lose any patients. So for the 14,000 patients there, if we don't get to them on the call, we get to them on a call back. So nobody is missed. And if you think about that level of demand in the system transferred either into mental health services, or even a distinct proportion of them, even 1% of those people transferring or showing up into an A&E department, you can begin to see the scale of difference here. You can see a 170% increase in women accessing perinatal mental health services, which again is an astonishing increase and benefit. A 33% increase in children and young people, accessing mental health services. That's a great rise, but actually it's also the place where we see the biggest single level of demand across Cheshire and Merseyside. And I think if you look at prevalence and incidence and do some population, public health analysis, about 70% of children and young people who have mental health presentation don't get seen by any service. So to increase it by 33% is great, but it feels like that's the sort of tip of the iceberg thing. And lastly, a reduction of nearly 90% of patients in Cheshire and Merseyside who are placed out of area for an inpatient service. And that's got two ramifications. One is it's terrible for patients and for their carers to be put 200 or 300 miles from where you live and where your support networks are. And secondly, it's a huge waste of public money to do that when we could do something different. And I think that's a stellar result. It puts us, I think, as an ICB, as one of the very few ICBs with a small number of out-of-area placements at this stage. And I think we'll be moving pretty rapidly to eradication of that entirely as we go. So the work plan, as we look ahead, if you look at the sort of blue titles at the top, I think probably, these are issues that, generally speaking, we've sort of talked about today, in headline terms. The work plan is very tightly driven by the work that's been done through Newton Europe. Gives us a very clear view on where the high benefit opportunities sit and lie. And for us, that will be continuing development of virtual wards. Although I'd say in a narrative, we should be thinking much more about broadening that to a telemedicine definition rather than just a virtual ward definition, which allows us to be a lot more adaptable in terms of how we use that sort of utility. Urgent care response falls IV at home, and DOS is the directory of services. What we are discovering is over time, and because I think of lots and lots and lots of variable commissioning over 20 odd years in the NHS and community services, so many opportunities for diversion that nobody has got a grip on where all of those opportunities lie, and which of them are actually now evidence-based, which are the types of services we ought to go to first. So that's a really significant work plan for the year. It's very focused on making sure we get to the right place. We can't easily put together a package that sort of says, well, here's the return on investment. But we do know that in terms of cost benefit, each virtual ward contact costs £650 less than a standard cost. We know that community IV is cheaper and more satisfactory for patients than hospital-based IV systems. And we know, Anne's talked about, the comparative data on falls. We know that there is a huge amount we can do on falls which benefits patients and delivers cheaper care as we go. But I'll get to the sort of contact stuff, what we could achieve here in the next slide, which is what could the impact be? I mean, we've made good progress over the course of the year from a position where we've actually had to describe, bizarrely and oddly, the data sets that we needed to work with. But now that we've got that, we need to move away in this year from doing bits and pieces of work that is sort of remedial action almost on the place that we are, and move into beginning to get scale and resilience in some of the work we do. This describes exactly what was stated on the last slide, but we've got an annualized opportunity, to think about almost 78,000 bed days that we could save, or the equivalent of 213 beds, or convert that into potential saving of nearly 33 million. But these are theoretical opportunities. actually, unless we begin to think about, I think, the collaborative having the opportunity to move from the stuff that we now know and understand to create an opportunity to do something different in terms of impact. What does that mean? A couple of simple examples in terms of the limitations we face. If you look on the right-hand side, this is urgent community response. And the bars are over time, and you can see right at the start, we were identifying referrals issues. We weren't getting enough referrals into the service. We did a lot of work with Northwest Ambulance Services, with local care homes. You see the impact of that over time with us reaching now what feels like a plateau in referrals. Now that might be able to go another 10% or so if we continue to do some improvement work and so on. But the task here is we've done an awful lot here now because of the attention we've paid, the data work we've done and so on, to understand what the provider opportunity looks like. And I'd say in this respect, we're almost maximised on this. The question is, what are we going to do to get into the grey zone, which is unfunded service? These are areas where we can do this. We can actually raise this by 100% if we've got a funding stream to do this. But we go back to, the point we've consistently made here is commissioning of these types of services has been incredibly lumpy, incredibly variable, and we need to have mechanisms that now allow us to substantially improve that position. And if you take that on, then I think our request of the ICB is to engage in an integrated community care programme. The collaborative can do it to a point, but it needs to sort of, in a sense, have the same endorsement that colleagues in CMAST have had, because making a change in these services is really important to the health of the population. It's really important to individuals, and it's really important to getting in and underneath all of the issues we've spoken about previously, where I think we can provide better care at a cheaper cost. I think that's perfectly possible. But we need to be able to build our infrastructure. We've got many of the parts of this infrastructure. We've got lots of good things that are in place here. But actually we need to now, I think, put what's a relatively limited scale and focus on discrete areas and lift that up into community services that are scalable. And the point about that statement is, I think we need to think about the inputs we need. We need more project management capability and change management capability. And that is a conversation I think that we don't need to spend more money, but we might need to think about where we put some more of our people in opportunity over time. We do need, in some clear places, clinical services investment. I think where the collaborative has said we're maxed out, we're a fairly efficient service here. If we want more, then we need to find ways to pay for more. And I would say I'd like to see ICB executive sponsorship around this to agree a plan like the one we had on the last slide, and to think about how we can get underneath some of the historic investment problems. I'll leave it there, Raj.
Thanks, Joe. And Isla, Tony, really comprehensive presentation, and you've crystallised some really important issues for us to consider. Just any quick general questions, but I'm conscious of time. I'm going to just laser in what the final point. Chris, yeah.
Can I just ask a quick question? Thanks, Joe. It was just around the virtual ward, and I just wondered whether the figures included the children's virtual ward programme that's running, because I attended a virtual showcase for that, and in the last 6-month period they'd saved nearly 8,000 bed days. I think there's something around the culture change, isn't there, around how we access services, and if we are working with our children that a virtual ward is the way forward, then our children, young people are our adults of tomorrow. We might think differently about how we access services.
I don't know, Tony, if they're included.
Yes, thank you. So yes, the figures do include our paediatric virtual wards. However, they are quite limited. with the programme previously, there was an emphasis on particular types of virtual wards, so for respiratory, for frailty. There was an opportunity to pilot things like paediatrics, and we did that, and it's been one of our most successful areas. However, of our 430 beds, only 20 of them are paediatric. We've been working with Alder Hay to say that whilst they hold the expertise, can we link them up with our DGHs, our other areas, to help them to provide paediatric virtual wards in the same way that Alder Hay are. So it's part of the development. Now we've got the permissiveness around the types of virtual wards that can be delivered.
Thank you. Okay, so what we've seen in the presentation is a clear articulation of the great stuff that's happened, and thank you for that, and really, but it also illustrates the enormity of the gap, both in terms of the care that we need to give to our patients. The illustration that you gave about children is a really stark example about that. And I think if I've understood the presentation, Joe, you're proposing an integrated community care approach that you'd like to develop, and you're asking, well, how does the ICB engage with that and make decisions, and how do we move away from lumpy commissioning, I think is your phrase. Graham, I think that's a question for you.
Thank you, Chair. Thank you, Joe and colleagues. I think the essence of what this comes down to, and this is a repeated theme that we discuss at this board, whether it's through Neil's questions on financial strategy or Ruth's questions on upstream investment and prevention, but we have largely been focused on, you know, the transition, recovering from COVID, and the stability that the organisation and the healthcare system has needed. We've kind of moved that this year into a focus on better use of resources and urgent care. And I think what this is really clear about is we need to now move this with our strategy into another space with what people largely called shift left. You know, more proactive care, getting more work outside of the hospital footprint, and indeed all the way left into that upstream shift in investment. And I think as we start to develop our financial strategies for future years, we have to be able to make a really clear commitment that says we expect the investment in some of the places the money is today to go down, and we expect the investment in some of these places to go up, and give a really, really clear commitment to that. I also think that as we come out of recovery, for each of those recovery programs that are in place that are consuming our program management resource, we have to think about how we put that back into business as usual, and then release some of that resource to support these types of programs. You know, you hear repeatedly, and you'll hear again later, that the ICB, you know, employs 1,000 staff. You know, a lot of those staff are employed doing the things that they were doing in a legacy setting. We have to challenge ourselves to say, have we got our best people working on the most important things that are available? And in the meantime, I kind of endorse all of the things that Joe and team have said here about we have to drive out the variation. We have to move towards consistency. You know, where there is variation, it has to be associated with population health need and not historic decision making. Now, of course, we've said really clearly that one of our organising principles will always be working in and around the 9 places, but we have to challenge ourselves really clearly that says why, and I'm going to pick on an East Cheshire example. East Cheshire, historically, same community services provider, but if you are a patient at Leighton Hospital, then a community intravenous antibiotic service is available to you to get you out of hospital sooner. If you are a patient of Macclesfield Hospital, that same service is not available, even though the start point investment was broadly the same. local decision making has prioritised the development of the service in one part of Cheshire and not in another. And we could repeat example after example of that. So, you know, in the meantime, we start with tackling variation, because if that service isn't in place, the money was there, but somebody else chose to prioritise it. Well, we need to revisit those decisions and get that standardisation. But then for coming years, we really need to get to a point where we can make a commitment to grow our investment in out-of-hospital services. But we're not going to do that today, Chairman. In principle, I agree with it, but we can't make a promise on the money today.
There's 3 asks from this collaborative, and I think you've talked to the clinical service investment ask, setting out the rich picture, the strategic context about how we should do that through the planning process. There's 2 other ones, the PMO change management and the ICB exec sponsorship. Could I ask you to engage with the collaborative, Graham, in September's meeting, come back about what is it we can do this financial year and then into future financial years to address some of those asks? Leave that for further conversation.
I thought I had addressed the PMO and change management one. I hadn't addressed the ICB exec sponsorship. I do agree we need to do both those, and we will come back with the answers.
Okay, thank you. Andrew.
Thanks, Chair. I'm really struck by by actually both presentations from the provider collaboratives and the scope for really ambitious sort of productivity improvements and outcome improvements as a result of that. Particularly in Isla and Joe's presentation, the interface with social care, particularly, I guess because of your priorities, the interface with children's social care is absolutely critical to this. And I do wonder whether, because we're not organised in local government quite in the same way across boundaries, that the provider collaboratives have demonstrated, whether there isn't some more detailed work we need to do across the Cheshire and Merseyside footprint, recognising, of course, the primacy of place principle, which is held very dear, as you can imagine, in local government. But I think the scale of change that we're talking about here, and the fact that, of course, our social care systems are in themselves really challenged, particularly children's, whether there is an additional action point you might consider about the integration between your programme and the collective programme of local government.
Joe or Isla?
It's sort of music to my ears. I chair a social care organisation provider when I'm not chairing CWP. I completely agree, but it's another thing on the list of things that there is an opportunity to do. And unfortunately, I get a long list of things. People say, "Oh, I hear your collaboratives doing that," and actually, what we're doing is adding to the list of things that we could do. So you'll see on the slides, there's lots of opportunities. But as you know, as we've discussed, those are not currently funded opportunities. And what you've seen there is the things that have been delivered from the existing funding envelope, some of which has reduced this year. You'll see some of that in the slides, and quite a limited resource to manage it. So I think it's part of the conversation that Graham's having there. We absolutely need to do those things, but we're really good at adding. We can see the opportunity, we can make the case for it. What we're actually showing is that even some of the things that are on there will be reduced in the coming year. So that's the risk I talk about in this endorsement. We understand why that's happening, but that's opportunity. And the member organisations are working really, really hard to deliver some of those things. But I think we're reporting that there's a limited amount more that we can do. For the things we talked about earlier, organisational SIPs, the pressure on people, there is just a capping off. So I don't disagree with the point, but it's going on the list rather than the work plan, I think, is where we are with things.
Joe?
Andrew, it's a very good question. It's the place when we started with this collaborative, as some people around this table will know, we were very clear that we thought the relationship to place was really important. But I think some colleagues at place find it difficult to reconcile a potential threat. And I get that, but so we set ourselves up as a collaborative in this respect that only looked at NHS providers and conditions, but conscious actually that, let's say in my individual chief executive's role, you and I have chatted many times about the problems that we have. But if we were able to think about formalising that a bit more, relationships with social care, relationships with housing, with criminal justice, all of those things, all of which out themselves at place, but they're systematic problems actually for all of the providers in the collaborative. So it might be time to revisit, but thank you.
Okay, so I think what we're hearing there is it's really important that we should try and organise ourselves at scale, and we'd be looking to leadership from yourself and Steve to help understand that. But Isla's point, which is, yeah, but we need some capacity to enable it to happen and benefits to come from that. Anne?
So when I take my provider collaborative hat off and put my trust hat on, my trust plays into 5 places in Cheshire and Merseyside and 1 place in West Lancashire. And the variation is always like totally inefficient, isn't it? So the fact that, you know, we really do have conversations about what side of the road you live on, madam. And if you live on that side of the road, you can be discharged today. And if you live on that side of the road, you can be discharged in weeks' time. And the reason for that is, you know, it can be something to do with social care, but it can also be something to do with, again, what Graham was alluded to before about what community services are available. So if you need something IV going on, intravenous going on in the community, some places do it, some places don't do it. And that, you know, multiply that up by every kind of service there is, and by then you've got the social care differences as well. And it's just the most inefficient thing ever, because you are having to do this kind of, you know, it's almost bespoke to every patient because of the combination of different things that are available in different places. So I think, you know, one of our big things needs to be, you know, we need to respect that places may have some reasons to be a bit different, but that the more we can take out this crazy variation we've got at the moment, the more likely we are to be doing the right thing by our patients by making the best use of the resources we've got, because the very variation we've got wastes money.
Thanks, Anne. Okay, so really important. Isla, Tony, thank you very much for presenting on this, and of course, Joe. We've got a series of things that we need to consider. We've asked Chief Executive of the ICB to lead on that, and Andrew will come back on that question about organising the scale, which Anne is really making a plea for there. We're going to move us on. And Claire, I think I can see you in the audience. Are you going to come and join us here? And Claire, you're going to present on the Children's and Young People's Mental Health Plan. And you've got a colleague with you.
Yeah, we can introduce ourselves.
Okay.
Thank you, Chair. So I'm Claire James. I'm the Mental Health Programme Director for Cheshire and Merseyside.
My name's Rachel Smethurst. I'm a Mental Health Programme Manager within the team.
Thank you.
Okay, thank you. So first of all, just to say that local transformation plans for children and young people's mental health, it isn't something new. They've been in place across England since 2015. Historically, they've been set at a CCG level. And we first were asked to move to a system-wide children and young people's mental health plan in 2020. It was delayed slightly because of COVID, but was subsequently published in December 2021, and at that time did involve quite a lot of stakeholder engagement. On the back of that, there's been some significant improvements. Some of those Joe mentioned in the presentation, including a 33% increase in the number of children and young people that have been able to access NHS-funded care. We've seen 26 mental health in school teams mobilised across Cheshire and Merseyside, and there's a further 5 being mobilised in this year. Every area now has 24/7 access to mental health crisis provision for children and young people. So lots of fantastic work for us to celebrate, but we know that there's more to be done. NHS England have now asked for a refresh of all of the existing children and young people's mental health plans. So earlier this year, we started a piece of work in collaboration with all of our stakeholders, including the voices of children and young people, parents, carers, professionals, stakeholders, to make sure that we captured everybody's voices in the production of the plan that we're going to talk about today. The plan has already been presented to the Children's Committee. It went there on the 12th of June. They've offered their full support for the plan and have recommended to ICB Board that it's approved today. So rather than Rachel and I describe the detail of the plan, what we'd like to do is just play you a short animation which has been produced with voices from the Alderhay Chameleons group, who we'd like to extend a particular thank you for. And we now hope that the technology works so that we can share this animation with you.
NHS Cheshire and Merseyside is the integrated care board responsible for planning NHS services for our area. They have recently updated the mental health transformation plan for children and young people. The plan's priorities have been informed by our voices, as well as parents, carers, stakeholders, and the professionals who work with us.
The plan is organised into 8 areas. Inclusive. Professionals will continue to listen to children and young people, parents and carers to ensure the services that are offered meet their needs. Timely access. Access to mental health support has increased by 33% since 2020. However, many people said long waiting times made it harder to get support. Improving access and reducing waiting times will continue to be a priority.
18 to 25 years offer, work will begin to design and strengthen the mental health support for young adults aged 18 to 25. This work will also focus on those young people who move on to adult services.
Eating disorders. Data suggests there has been an increase in eating disorders over the last 5 years. We want children and young people to be able to get support when they need it, and we want to make sure it is available for everyone, no matter where they live.
Crisis response. Over the last few years, community mental health crisis support has been developed. There are plans to review this with partner organisations like the ambulance and police services to ensure support is easily accessible locally in our communities. Appropriate places of care. Data shows an increase in children experiencing complex social and emotional difficulties. Work has started to look and address gaps in current support for children and young people with the most complex needs.
Specialist mental health care. Our NHS-led provider collaborative, known as Level Up, is working to ensure that young people experience high-quality specialist care as close to home as possible and that care is connected to their community.
Innovative. We want to use research and new ideas to find answers to current challenges with the overall aim to improve outcomes for children and young people.
Children and young people are at the heart of this plan.
NHS Cheshire and Merseyside will keep checking to see if the plan is working so we can make sure improvements and transformation of mental health services take place. Children and young people will work alongside them to make sure we meet the needs of our young people in ways that work best for them.
So the plan reflects months of work across the system. As we said earlier, it's involved very varied stakeholder engagement, and it's really an excellent example of co-production, which hopefully has just been demonstrated through the animation. The ICB requirement is to publish a plan on the public-facing website in the summer of this year. So the plan is, as Rachel will come on to the recommendations, that subject to approval, the plan, an animation and an easy read document will all be published on the ICB website. So I'll pass to Rachel for recommendations.
I just wanted to add one final point, actually, just to address something that Andrew just raised around the integration with local authorities. So we've been working really hard with the 9 DCSs, so the Directors of Children's Services across our 9 local authorities in the production of this plan, and together formulated the priority areas alongside them. We will then be working with what's called the Cheshire and Merseyside Children's Emotional Wellbeing and Mental Health Programme Partnership, where a number of programmes at scale come together to work collaboratively together and to be innovative together to reduce those, to really focus on those areas that we're both seeing as big challenges, both in care and in health. So the board today are asked to note the supporting papers and the engagement that has taken place across the 9 places to formulate the plan, to agree that the plan will be reviewed annually and will be overseen on behalf of the Children's Committee by that programme partnership that I just described, which the DCS is a part of. And please note the recommendation by the Children's Committee to approve the plan. My final thanks is to the young people that helped to animate the animation.
Thanks, Rachel and Claire. Any questions or comments? Or should have said, I need to step out of this conversation actively because I'm chair of the Children's Committee that's already approved the plan. Any questions, comments? Ruth?
Thank you very much. It's great to see a real step change in co-production and engagement to try and shape the plan. I really welcome the emphasis on this. I noted the Children's Committee who looked at it asked for the implementation plan, and clearly, whilst what you've presented today is very broad and it's clearly benefited from service user input from children and young people, the real test is what are we actually going to change and how will we hold ourselves to account for having done it. So my question is, when will we have the implementation plan to consider? We're already into 2024 financial year. How long will it take for us to get to the more granular level of commitment to deliver this plan?
I would say that a lot of the implementation plans at place are already being developed. What we're also working towards is a system level oversight of that implementation, together with some metrics, so we can see and monitor the progress. That will be collectively reviewed each quarter by the programme partnership and then reported up into the Children's Committee so that we can be as transparent as possible. We'll also be taking the work back to our children and young people so they can hold us to account as well. So the place level plans are developing, and also there is a view that those place plans will be considered within place governance, again to have that multi-stakeholder oversight and view of.
I just wanted to clarify, whilst they're being developed, we're 4 months into 2024 financial year, when will they be signed off and ready to be held accountable for?
I think that's something that we'll have to agree with each of our place directors in terms of their own governance structures, but we'd certainly aim that, subject to the plan being approved today, to have full implementation plans signed off by September.
It's a really good piece of work, happy to endorse it and so on. My question was sort of the same as Ruth's, which is it's about getting stuff done. It's about getting stuff done that's sensitive to place, but aggregates to where it makes absolute sense. I have looked at the governance structure and I'm very confused by it. It's very complicated governance structure, not confused by it. I wonder, and we can take this offline, if there's something we can do to make that a little bit easier to manage. And secondly, I'm not sure we've entirely got stakeholders in the right place in the matrix. So if I take my provider collaborative hat off and talk about my organisation, we're not entirely sure how all of that governance works and how decisions get made that then get calibrated in terms of risk against particular organisations. Given that, for example, my organisation is the biggest 18 to 25 provider for mental health services, but there's something about proportionality in that. But these are things that won't stop it happening. It's about improving what we've got.
I'll just make a comment on that. I know there's been, over the last 6 months, I think, and most certainly just recently, some really good conversations with Merseycare on some of those issues that you've articulated. And I got a note from Simon Banks that followed a meeting with Trish to say, we think there's a good way forward. That's give you a little bit of reassurance, but we'll look at the detail in due course. Graham?
So I'm going to come on to a very specific question, but before I say that, I think the first thing is, one, I also endorse this piece of work, and the board should endorse it, Chair. These things will continue to evolve. One of the things that I have resisted saying so far today is the plan is only good at a point in time in the context it is set within. And this brings me on to my specific question. And I don't expect a comprehensive answer today, but we all know that there are a range of things that were placed within the new government's manifesto. Yeah, the new government are now in the process of formulating that. That in turn will formulate NHS's planning guidance for next year. And again, knowing whether or not money is going to flow with some of the manifesto commitments or not is very important. But one such example is the new government made a commitment about access to mental health in schools. Now, we know we have mental health in schools now. And if I take you back to the Provider Collaboratives presentation, there's a line in there that says we now have 31 mental health school teams across the patch. Now, whether they are compliant with what the new government's manifesto commitment describes, or whether or not we now have to remodel those teams and work in a new way, we're going to have to wait to find that out. So the important thing is, against the backdrop, we know that we've got 31 teams. Right now, the key thing is to just have a look at coverage, consistency, take up and access rates. So we know that what we've got is doing the best it possibly can do, but knowing we are going to have to continue to build for the future. Thank you.
Thanks, Graham. I think that's for noting, really, Claire. That external context is going to be really, really important to any adaptations that need to happen. So I'm going to seek the board's endorsement for this plan. Yes? Yep. So Rachel, Claire, it's a great piece of work. I really like the fact that you brought that video here to hear, and we could hear firsthand the voices of the children. So thank you very much. Okay. Yeah. Rob? Welcome, Rob. Just introduce yourself and...
There we are. Is that on? You can hear me?
Yeah.
Okay. So I'm Rob Cooper, Managing Director for Mersey and West Lancashire Trust, and I'm here to present the Shaping Care Together Case for Change. Okay? Okay, head straight into it then. Okay, so people will have in their papers the full Case for Change. They'll have the cover document as well for this, so I'll go through the presentation. But please stop me if there are any questions, or we can pick up at the end. So content's fairly straightforward. I'm updating two things, laptop and the screen. So programme background. Shaping Care Together covers the area Southport, Formby and West Lancashire, Southport and Ormskirk hospital sites. And the programme sits across two ICBs. So that's Cheshire and Merseyside, who are the lead ICB, and NHS Lancashire and South Cumbria. One acute trust to Mersey and West Lancashire, and NHS Mersey ICB lead commissioner, as I've already noted. So just a little bit of detail in terms of the programme background. So people will be aware that there have been various different reviews, particularly across Southport and Ormskirk, certainly since 2015, all of which described the need to sustainably manage those services and for a solution going forward for the organisation, and this then feeds into the Shaping Care Together programme. Certain services were identified as fragile and solutions needed to be put into place to stabilise those fragile services. So SCHK were identified as the strategic partner for Southport and Ormskirk, and as of September 21, an agreement for long-term collaboration was put into place. July 23, as people will know, two trusts came together to form MWL. So that then led into a number of different programmes, Shaping Care Together being one of them, and that does run in tandem with the creation of MWL. And when I get to the point later on in terms of the focus of Shaping Care Together, and particularly this Case for Change being urgent and emergency care services, it is worth noting that the programme that's run alongside for MWL covers off all of those other services that we talked about that were fragile. So we're not doing this independently, and we're not forgetting all of those other services that were identified as being fragile across Southport and Ormskirk. It's also worth noting that phase 2 of this, once we get through the consultation, we get to a preferred position that can't be done by the trust alone, cannot be delivered by the trust alone, and MWL, certainly the Southport and Ormskirk sites, won't be sustainable until the issue is resolved and will require capital and transition funding. So, codependent programmes, and I've noted these because I think people will be aware, or those who are aware of the history of Shaping Care Together, but certainly the history of Southport and Ormskirk, is that this programme has been running for some time. We're now getting to a point where we are making progress, but it is worth noting that a number of these codependent programmes have taken people's time, effort and focus, hence the reason that Shape and Care Together at that point wasn't the priority. Of course, we know that ICBs have been formed. We've had the COVID elective recovery programme, which obviously took the time of all of the system to be able to focus on. The agreement for long-term collaboration worth noting, but also the work that's being done by CMAST in terms of the clinical pathway prioritisation programme around orthopaedics, ENT and dermatology, and that links back to that work that I talked about in terms of fragile services, so that programme is running alongside it as well. And of course, worth noting, I'm sure you've heard about that, the alignment of Cheshire Mersey UEC recovery programme, and us really thinking about this as part of a system, not just as a standalone organisation. So noting the public engagement to date, extensive public engagement in 21-22, a number of thousand survey responses as a result of that, widespread engagement with public, community groups and of course the voluntary sector. And all of that helped shape our thinking in terms of the service change and what was required, and I suppose our focus then on urgent and emergency care, and underpins the case for change for today. Equally important, worth noting the level of engagement that we've had with oversight and scrutiny committees and our councillors, other elected officials. So why are we starting urgent emergency care? So of course it's an opportunity to access safer, high quality services that are fit for the future, but I think people will recognise that urgent and emergency care services are fragile, and particularly over Southport and Ormskirk, and the configuration of that isn't really helping that situation. There are significant service codependencies. We do know that we're lacking a 24/7 paediatric ED, and some of that has resulted in then our paediatric emergency department closing overnight on the Ormskirk site, and we need to come up with a solution for that. Workforce quality and safety pressures, of course, are very much apparent in urgent emergency care services, and we need a sustainable solution for that, and financial sustainability comes into it as well. Ageing population, of course, as we're aware, but in terms of the Southport footprint, and Ormskirk actually, the increase in housing, so the new developments mean that that population is growing, and that isn't necessarily just ageing population, that's also with families as well, so thinking about younger people, children, as well as older people. So, what are we working towards? Addressing the immediate issues, of course, and you'll see in the diagram on the right-hand side that there's a number of codependencies in relation to the urgent and emergency care programme. But as per the discussions that we've had with various people, including the non-exec directors from Cheshire and Mersey, noting the independencies of services with mental health, primary care, ambulance services and palliative care. So clearly, a lot of work that joins and links across those pathways, hence the reason that we've engaged with them as we've gone through this process. Of course, we need to make more efficient and effective use of available resources to provide better care and better value, and ensure that resources are used in a way to help improve patient flow and safety. And again, worth noting, and part of our discussion that we've had previously, certainly with, again, the NEDs in Cheshire and Merseyside, was around that strategic alignment to place-based work. And this programme does ensure that cohesion, and we're working with Place to ensure that we are meeting the demands of the local population and in line with the Commission services. So a couple of slides here that I'm not going to go into detail, but this is around the core elements of a case for change. What should be included in that? It certainly is worth noting at this moment that we've been through the stage 1 assurance process with NHSE and had really encouraging positive feedback in terms of the progress made to date. Second slide for the same core elements, so I won't cover that one. But to note what it is and what it isn't. So it's a case for change is there to objectively inform and enable participation. This doesn't seek to lead stakeholders toward a preferred option. This is just signalling the start of this engagement and consultation, and it is led by the ICB. So our approach, as noted, a basis for engagement with all of the facets of the population, but also staff and other organisations. A thorough but plain English approach, and there are various different forms in which this has been produced, so an easy read, various different languages. We are producing a video at the moment as well with subtitles. Enhanced accessibility obviously covers that, and communication through design. I'll go through the actual design of the document as we move through, which notes that point. So, a case for change and the contents. So it's split into two halves. First half, the background, which we've covered here, and the second half, which gives more detail as to why we're actually going into urgent emergency care first. The focus of that picks up on health inequalities, picks up on local population, picks up on demand, etc. So our core messaging as part of this case for change, but also the move to actually realign, if necessary, those services. It's around delivering safe, excellent quality and sustainable services. Solutions that make the best use of funding, staffing, our estates and other resources available to us, and providing the same quality of care to everyone all the time. It is worth noting that because of the position of Southport and Ormskirk over a number of years, local services haven't been offered to the local population. That's moved out to various other organisations. This is very much at the heart of what we're doing, bringing that care closer to home and to where people live. So what will be better? This has actually changed. I've had a few iterations of this, and we've had a few iterations of this as a result of the engagement that we've had, but also in terms of applying some of the Health Watch guidance in terms of people's language and the best use, the best way of accessing local population. So reducing waiting times at A&E, that's an obvious one. Less cancelled operations, because we're actually focusing our resources on urgent care that's effective, and then not needing to take more of the elective capacity to utilise for non-elective demand. Dedicated emergency care for everyone, all day, every day. Better urgent care provided closer to home, and an NHS that can meet your needs today and in the future. So, a big part of this is co-production. Lots of clinicians involved across all of those organisations that are noted there. So MWL, NWAS, Merseyside, HCRG and Primary Care. Cheshire and Mersey Commissioners, Lancs and South Cumbria. Of course, the members of the Shaping Care Together programme board, and that is made up of a number of people from the above organisations as well as are the workstream leads. Lots of focus from Health Watch and voluntary services as well, patients, public service users, and of course NHS England. And I've noted that stage 1 assurance check, which has come through with some positive remarks. So as part of the stakeholder feedback, what's that fed back to us? That we need to distill the content appropriately to different audiences and make it accessible. That's noted. That we ensure maximum accessibility, back to the same point. And feedback accounted for in pre-engagement phase activity, which we have done. In terms of our design, and I talked about that earlier, this is the format of the case for change, but you've seen that through the document, and hopefully that makes it easier to read, and we'll continue to make various different versions and iterations as we move forward. So where does it sit in the programme? At the moment, we're at stage 2 there, tripartite board review for case for change. Has been approved by MWL, it's been approved by Lancs and South Cumbria, and today is the final stage of that tripartite board review. And then we move on to a period of focused stakeholder engagement, which gives us a long list of options and then takes us through to a pre-consultation business case at the beginning of next year. The other point that I was going to raise today, and that's around formation of a joint committee of the two ICBs, and that's just to help us provide a more effective vehicle for making decisions going forward. Would be representative of all appropriate organisations, partners as well, and take us through to that pre-consultation business case. And if that is approved, terms of reference would be developed and shared with the board in September. So, final slide from me, and the ask of the board today is to approve the case for change, approve the commencement of the pre-consultation engagement by default of improving that case for change, and approval to establish a joint committee. Thank you.
Thank you, Rob. Let's take the first 2 bullet points first. So seeking people's views and comments on approving the case for change. Neil?
Yeah, thanks, Rob. That's helpful. and the slides and presentation were helpful. So I think the case looks good. But I'm just looking at the case for change NHS guidance. And one of the 5 criteria. The last one is a review of the financial considerations. I'm not clear what the financial considerations and potential risks are. In the slide it talks about self-sufficiency, becoming more efficient, then you refer to the need for capital and pump priming. So I'm not clear what the financial considerations are that we should be considering.
Okay, so I mean at this stage this is about use of resources. What we will be moving to at the next stage, and again we checked this with the regional team as we went through this process, and that it was enough to be able to consider it in terms of there will be an impact. As we move through to the long list of options, they will all be worked up in terms of revenue and capital impact, and again that will be shared as we've discussed previously. Well, the options that in the long list are wide and varying, and that is around at one end of the scale having to move all services over to Ormskirk, and you can imagine that that would be a significant level of investment. At the other end of the scale, expanding the accident emergency department that's already in place, so it is fairly significant.
Yeah, it's just the expectations that we might rise, and is the capital availability going to be there at the options, but clearly it's something we'll have to consider.
No, absolutely,
yeah.
And what this isn't is seeking your endorsement of that investment, but certainly seeking the endorsement that there will need to be some investment to some degree, and we'll work that through.
Any other questions on the, this is a case for change, it's not approving the investment. So I'm going to take it, we approve and support the case for change. Joint committee, Claire, I think I'm looking to you.
Yeah, excuse me, yeah, thank you. So I've had the pleasure of working with Rob and colleagues on the Shape and Care Together programme board over the last few months, and as Rob said, it has been through stage 1 checkpoint with NHS England. Got positive feedback probably last week. I think it's important to note, obviously Rob has had to present this to 2 ICBs because it, because the trust covers two sort of geographies. So we're proposing that we establish a single joint committee of the 2 ICBs that going forward we can consider this once, which is much more appropriate. We can have the conversation, we can understand the patient flows, the issues across all population, rather than having to sort of present in two occasions. So we'll bring the terms of reference to the September meeting if the board agrees, and from then we can get various meetings set up at various checkpoints through the next sort of few weeks and months. So I think, really supportive of the case for change. A lot of work has gone into this, and I've seen various iterations, and I think it's really important that we acknowledge that amount of work, and we can do that, I think, next steps through the joint committee.
Okay, good. So approval for a joint committee.
Okay.
Ruth?
I'm happy to support the idea of a joint committee. I think it's a very sensible way forward. Before the final work, the option appraisal comes to that joint committee, how do you envisage the option appraisal incorporating public, patient and staff perspectives on the choices, so that the committee, when it meets, has a real sense that there's been proper co-production?
Yeah, so I mean, as a result of hopefully the approval today, and I don't want to preempt anything before Chair's actually given that, that nod at the end, but with approval today, we start our public engagement. So that public engagement commences from tomorrow and carries on for the period until October and November as we work up that long list of options. So that then feeds into the pre-consultation business case that then goes to full public consultation in terms of those options.
So does that mean there will be public, patient, staff engagement in the option appraisal process?
Yes, absolutely. Well, at the heart of it. So that's what we start with, and we go out to public, staff, organisations, so that there's a significant period of engagement that commences now to build up those options to enable us to take that forward.
Can I just come back again? Sorry. I absolutely recognise the engagement. What I'm asking is, when you get the feedback from the engagement,
yes,
and somebody sits down and then looks at the options, will you have engagement of public, patient and staff representatives in that option appraisal?
Yes, that's
decision?
the intention, yes.
That's what I was trying to...
Yeah.
Well, it might be useful. Could you outline the process for us subsequently?
Absolutely, yeah, absolutely.
Get that engaged and how it influences decision making.
We'll do that.
We can bring that back in September.
September, okay, good. So, I'm going to assume we've approved the case for change, we've approved the establishment of the joint committee, start of the road, which I know it feels already long for you and colleagues.
Yeah,
but it's
well
the
aware
start
there's a
of
lot
the
to
road.
go.
Okay, thank you. Thank you.
Okay,
Good.
thanks.
Thanks, Rob. Claire, I think you're on next.
Yes, thank you. So I think this next item actually sort of follows on very nicely from that conversation about engagement, consultation, pre-engagement consultation and co-production. So this is the draft involvement plan for the ICB. It has already been endorsed and approved through Quality and Performance a couple of times, finally in May, and I'm sure Tony will bring something to that. But it was important to bring it in full to the board, considering we brought the inaugural report to the first meeting back in 2022, and we'll be bringing back future versions in a couple of years' time. So it sets out our overall ambition for working with people and communities, reflecting national guidance and highlighting how we work with partners, including Health Watch. And while the involvement plan details our engagement approach as an organisation, it's really important that we focus on putting in place individual arrangements for specific pieces of work. And I think that's just an example here, as there's no one size fits all. So we build plans around different themes and issues and look to work what's best for people as we try to reach them. So we've had examples today around how we're going to engage lay members to work with the Women's Children's Services and Liverpool programme. We've got conversations around our citizens panel, changes to our community voices, how we work with our populations around general practices as well. So I think we want to raise awareness of the plan. It's very much about not just how we work with our communities and our stakeholders, but how we work with our staff as well. And last week we held 2 co-production training sessions for staff, providing practical advice on how we involve local people in equal partnership. So I think I commend the report, and I'm really pleased that Maria, Mike and Sean are here, because it's been a fantastic piece of work for the Communications and Empowerment team, and I recommend it to the board.
Thank you, Claire. Any questions or comments? Ruth?
Building on my comment on the previous paper, really welcome this commitment to step up the approach to involvement. And I noticed that there's consideration of further opportunities for embedding involvement in governance in particular. So we have the public and patient voice in decision making. So I really welcome that. My only question was, and I say this based on experience with the National Institute for Healthcare Research. I'm chairing a funding panel at the moment, and the public participants are absolutely brilliant, but they are supported by training and funding. And I wasn't sure what the approach was in our strategy in terms of how we make sure people are supported to do this well.
Well, I think Maria's here and she might be able to answer that in more detail, but we are committed to support people to work with the organisation. Chris has talked about inclusive recruitment, so I think it's very much that joined up approach in terms of recruitment of formal posts, but recruitment of staff and the public to work with us. So we're committed to that. In terms of reimbursement, I think we look at that on a sort of a case-by-case approach, really.
Okay. Any other questions, comments? Receipts. Just one for me. It's section 10. Ooh. Sorry, Tony, I forgot what you...
Okay, just to emphasise the point made there, this appeared twice at the Quality and Performance Committee. In an early draft, there were a lot of comments, a lot of positive comments, but also some significant challenges. The committee was particularly pleased that those were taken on very promptly and included in the final version. Strong issues from the local authority partner member was this is essential for co-production. You need a mechanism and a policy to support that. So, as I say, it was very strongly supported, and also by Health Watch.
Thanks, Tony. Question for me is on evaluation and impact. So we had the plan 2 years ago. Do we have any view how impactful that plan has been to date? Useful to understand that. And also, again, looking forward, what are the key metrics we're going to monitor at board level that enables us to understand we're doing engagement in the way that we think we want to do it and it achieves the outcomes that we want.
Can I come back with answers on those,
You
Raj,
can.
please? That's
You
okay.
can. Okay. So the ask is to approve this. We've got some further work to come back to in September. We're happy to approve it. Yes, thank you. Go on to the Claire Watson show next.
Well, that's only because all the other agenda items have been moved around. So.
Yeah.
Okay, so I'm really pleased to present the final version of the Cheshire and Merseyside NHS delivery plan. So this is a core component of the refreshed 2024-29 joint forward plan. The NHS delivery plan is one part of a trilogy of documents which form the joint forward plan. So the other two are the HCP Healthcare Partnership Altogether Fairer Delivery Plan, which is going to come to the HCP in August, and also the Place Partnership Delivery Plans. Section 2.7 outlines the 4 key delivery themes or chapters. So the focus on this year, on 2024-25, focus on recovery, transformation of our services, innovation and new use of technology, and improving outcomes in population health and addressing health inequalities. Our challenge this year is to both focus on the future as well as deliver today in terms of recovery, finance, emergency care, workforce access, all the issues we talk about regularly. And we're really keen that we need to represent and respect our partners' priorities and talk to all 4 of the ICB's objectives, so improving population health, reducing health inequalities, achieving financial balance, and contributing to the social and economic development of Cheshire and Merseyside. I'm pleased that this plan does all of these things. I would like to thank Neil Evans and Stephen Wood in particular for their leadership and work on this. We need to continue to deliver and act on the priorities and objectives within the plan. I believe it represents the focus we have on today's priority while representing the enormity of the work and responsibilities the ICB has. So Graham's already alluded to the new government, and we understand that a new 10-year health plan will be published next spring. We'll be ready for that, to respond to that, and obviously use our plan for this year to build on. Our plan sets us on the right path to meet the challenges ahead, so I commend it to the board. Thank you.
Thank you, Claire. Any questions or comments? We've seen iterations of this before. Yeah. So we're comfortable? Okay. Endorsed and supported.
Thank you.
Thank you, Claire. Should we go on to the assurance framework?
Yeah, let me just, if I could just, hang on. Okay. Sorry, I've done something to my computer, so it isn't intuitive anymore, so I can't access anything. So, I'm presenting the 24-25 BAF for approval and to provide an update on Q1 progress. So Risk Committee, and if you remember, that's the exec team meeting on a sort of 6-weekly basis, but the Risk Committee has received the principal risks in light of progress from last year and undertaken a review in terms of our strategic challenges and revised priorities for this year. This year's BAF retains 9 of the existing principal risks. It proposes P3 is de-escalated to the operational risk register and proposes to include and introduce a new risk P11, digital infrastructure for key clinical systems. And I'm sure John will talk about that later. The 2 critical risks are P3 and P7, which are the ICB's key areas of focus behind our recovery programme, so that's financing and urgent emergency care. You'll see in the report and appendices the controls, mitigations and assurances for each of our 2 critical risks, our 5 extreme risks and our 3 high risks. And I'm sure director colleagues will be able to answer questions on each of these. We've taken this through audit committee already, and we've introduced 4 levels of assurance to provide greater delineation between levels of assurance. So rather than the 3, where you can always pick the middle, we've gone for 4, where you can't always pick the middle. So we've now got significant assurance, acceptance, acceptable assurance, partial assurance, and no assurance. 9.5 summarises our recommended and refreshed BAF for 2024-25, and 9.6 details the proposed changes from the position at the end of Q4 23-24. If we turn now to Q1 of 24-25 of the 10 principal risks subject to board approval, P7 and P9, statutory finance duties and ICS workforce, require greater scrutiny and are awaiting further intervention. It is a detailed report, we acknowledge that, and it has been discussed thoroughly at Audit Committee, where there's been considerable interrogation of the risks and the controls and mitigations, but happy to take any questions. Thank you.
Thanks, Claire. Questions, comments? I think there's a lot of information in this report, and it's of critical importance because it helps agenda items onto the board, but really, really importantly, informs Graham of the priorities that we expect the execs to work on. I'll just come to digital in a sec. The ratings that we see, the key risks, do we agree with the ratings, and do you think there are any major risks that are absent from those top 9, I think it is now? Yeah, people comfortable with the way it's rated? So we can see that there are some, those 15s, there's the 220s, and digital infrastructure is the new one. And just a few words about why that's there.
Thanks, Chair. Last year's BAF, the digital risk was quite specific, and it was focused on our provision of analytics capability to provide our population health insight. And at this previous meetings of this board, there have been questions around our cybersecurity risk. So the proposed new risk is a BAF risk that represents the potential impact if we don't get our cyber security measures appropriately robust and consistent. And there are 2 lenses to look through here. There's a responsibility for the ICB on the systems that it uses and manages on behalf of its staff and for wider primary care. And then there's a wider system risk that we feel it's appropriate for us to manage at this board, because of each provider will have its own measures and strategy and BAF risks around this. But in the event of an incident, almost inevitably it goes beyond one provider if there's malicious activity. So the new proposed BAF risk aggregates those two views of the world. Currently scoring 16, there is quite a detailed plan being implemented, but the assurances around some of that are still showing as amber, because we've not, for example, we're looking at trust level reporting on a range of measures and giving us an aggregate view of vulnerability. And that, at the moment, that's on best endeavours, so we're putting some formal governance around that to manage the risk as an aggregate. A whole range of joint endeavours around managing supply chain, and in the medium term looking at pooling resources and creating a central cyber security team. So I think we're well on the way to having sort of some more robust reporting and data on which to assure ourselves, and working more collectively. But I think what the plan envisages is bringing some of that assurance data back up to this board through the appropriate committees in the autumn. And I would expect some of our controls to be stronger and more demonstrably stronger by that point.
Okay, so that'll be November board.
Yes.
Okay. Hilary?
Thanks, John. I'm just wondering about the consequences for our smaller organisations, particularly our third sector partners, and whether the explicit standards and the harmonisation of standards that we would require for good commissioning could disadvantage them, and how, therefore, can we support our smaller partners or indeed suppliers.
It's an important challenge, and I think the nature of the funding that we're working with here, it comes in discrete packages from the NHS nationally to address specific problems. I think where we can work more broadly as a collective is around those standards and setting expectations with third-party system providers. I guess the core team we're describing, developing, would potentially be a system-wide asset and could support some of the smaller organisations. And I think even within our NHS provider trust, there's different abilities to respond to this in terms of resources, and the intent underpinning this is that we help we bring everyone up to a minimum acceptable level. So I think the current plans are admittedly quite NHS focused.
Yeah,
so it is a question, how do we take that, how do we go into the broader circles of our economy?
Yeah, I just think it's a consequence we need to be aware of and anticipate how we're going to manage that within this risk. So thank you.
Great point, Hilary. Thank you. Naomi?
I know this has already been mentioned previously, but it was just whether we've already discussed the collective action of general practice and the impact that that could potentially have on the wider system. To quote the BMA proposal, it's to have minimum impact on patients but maximum impact at system level. So whether that would be incorporated within this risk register and whether that's something that we need to look at here, or is that going to be looked at somewhere else?
Excuse me. It's part of the conversation, as you know, at System Primary Care Committee. I think whether it's a BAF risk per se, but I think it's very much a corporate risk, and I'm coming on to that agenda item next. It's not actually identified at the moment, but it will be escalated through System Primary Care Committee and placed onto the corporate risk register.
Good point. Any other questions? Just looking at the table at 9.11. We've talked, I'm just looking at the 15s and above, we've talked about most of those risks today or in other forums. But on health inequalities, I'd suggest reporting isn't green. I think we've heard today some opportunities for improving health inequalities, and we can capture those that was making to Owen, because we're possibly underselling some of the work that we are doing on health inequalities and also illustrate other opportunities. And it's a question of clarification for me. Where does lack of funding feature in controls? Is that in plans, or do we have a view on where that should be? We could say that by plans we mean agreed funded plans. If we do say that, we need to act on that definition. Should we work it in that way?
Yeah.
How else would you work it? Chris, have you got a comment on that?
I suppose just to say we've tried to reflect that in the individual risk scores. So if you see on P9, that was previously a lower score, but we've taken into account the fact that we've got financial challenges, which means the minute you start to put some restrictions on things like recruitment, we therefore will not have a workforce that's reflective of our local population. So the financial situation was the factor that took our score up on that. So it might be reflected in individual scores.
Yeah, I'm sure it's reflected in individual scores, but I'm just looking at the controls and how do we see that important element reflected in controls. I suspect it's funded plans.
Yeah.
Okay.
Can I just come back to the health inequalities one? It's probably green because it's around our health inequalities duty, and I think it's about the definition within the BAF. So I think sometimes it hides the issues around health inequalities, but on the forward plan we have a substantive agenda item in September on population health and health inequalities, where we can bring as much or as little information as the board would like on the work we've been doing over the sort of past 2 years.
Okay, good. So we're seeking. Ruth?
On the financial risk, I'm mindful and informed by Neil's intervention earlier about needing a sort of service and financial plan. We only talk about having a financial plan, and in fact, the medium-term financial strategy is rated as problematic. So I just wonder whether we've got the right focus there in terms of what we're really saying is we need a strategic plan for services which incorporates a financial element. Yeah. And I don't think we've captured that clearly here.
Yeah, that's really fair.
Yeah. Okay.
And I think that is part of, I think that's a really fair comment, and I think that is part of what I was trying to say before around you can't start with a financial strategy. You can start with your sort of challenge that you're facing, but you need the service strategy to be able to then work through the financial elements of it. So we can change the wording in the back for that. Is that what you're suggesting?
Change the wording, but also looking to see the plan, because it says it's going to be ready by the end of September, and I know Rowan's developing a clinical services plan. Yeah. If I got the right terminology, so I just guess we need to tie all this together and be clear on what we're going to see and when.
Yeah.
On the medium-term work.
I agree. I think in September, what I was planning to bring, and that was a response to Neil, was sort of a refresh of the long-term financial model and the key areas of opportunity that we're working on, with as much as possible financial opportunities identified, things that we're targeting. So if an element of it is the Liverpool Clinical Services Review, or the Cheshire Review, or the work we're doing on urgent care, or Shaping Care Together, which we've heard today, we do need those to kind of progress. I can sort of identify opportunities, but we need to work together on joining up those strategies with the financial enabling elements of it. So September won't be that point.
So just before I bring in Neil, I think you want to come in, don't you? We have just signed off the key delivery plans. And the key delivery plans are supposed to, and they do, I think, set out our approach to the clinical strategy and the overall organisational approach. And I know the detail is yet to be developed in CUM, and there's a lot of work to be done. But I think that's where I would point us at this stage. Neil?
Yeah, I think that's right. I think what we'd be looking for in September would be a 3-year financial strategy, but a plan based on what we're doing today. And to understand what the benefits of recovery would be and the potential benefits of the other service reviews. But it can't be a full service review because we're not anywhere there. But it's based on, if we did nothing and on our planning assumptions today, where would this year take us in 3 years' time? And what mitigations do we believe we're going to put in place that will have an impact? Would that be fair, I think?
Can I?
Yes.
Can
It's
I?
not a financial strategy though. I think that's more of a, and that's what makes me nervous when we call that financial strategy, which I think that's more of an assessment of our financial challenge. So we're nowhere near that.
And I just want to support Raj's point around the NHS delivery plan. There are 4 chapters or 4 key. So there's today, delivering today and the focus on recovery, but there's also about service transformation. And within there's a whole raft of priorities and programmes. Whether we need each one has a plan and a work stream, whether you need a strategy for each of those, but you've got a whole raft of work, and it's not just the ICB staff, it's the ICS and all the partner organisations and the networks and the programmes that we commission and who work with us. Then we've got sort of a chapter and a theme around health inequalities and population health, which will come through our Altogether Fairer and the HCP plan. And then you've got sort of the innovation around digital and that area. So the delivery plan we've just signed off, I hope covers off, the ICB's work and our services and our programmes for the coming year. So.
Can I suggest, outside of the meeting, do a pictorial on one page, just to show all the different things that are going on?
I'm hoping it is somewhere on
Okay, well, yeah. Good. So if it's not here immediately, but just point us towards it or separately. Okay. And people, so we were seeking approval of the BAF. People, subject to those comments, people happy to approve the BAF.
Yeah.
Corporate risk register.
So final one for me. So the ICB corporate risk register comprises those risks escalated from committees and directorate risk registers with a score of over 15, so 15 plus. So we have 10 of these, 5 are deemed as critical and 5 extreme. So you can see those in the report, and I'm not going to go through those. So we work through, and with the attached appendices, you can see all the mitigations, the controls for those as well. I think the key thing for me that's come out of today's discussion is we've covered an awful lot of the sort of risks in the BAF and the corporate risk register in our discussions today. So I think it just sort of gives me confidence that we're aligning and providing oversight of the risk that we're presenting at board. So I'll leave it there, but any questions to myself and colleagues?
Anne?
Yeah, given the conversations we've had about the urgent care problems, it just feels a bit strange that that's not even in that list of risks, because obviously if the actions that we've agreed upon to improve that don't turn out to be as effective, or something else plays in, so there's another increase in demand or whatever else plays into it, then that could be a really big risk to the quality of service that we're delivering. It just seems a bit like, that seems to me to be, where is it in there?
It's P5.
It's in the BAF.
But it's not in the risks in the
No, but
corporate
it's
risk
because
register.
It's been escalated.
It's been escalated, so it's a principal
So,
risk, which
okay, so
it
you,
almost
that's
is more,
covered over
more
from there.
important.
Absolutely, yeah.
Yeah, so it's,
Okay.
it's in the BAF.
So we don't need it to be in
No.
this because it's in that. Okay,
Yeah.
right, thank you.
Okay, so any other comments before I seek your approval? Risk register. Okay, thank you.
Thank you.
And Chris?
Thank you, Chair. So at the March meeting, I was asked to produce an annual review of the workforce issues and actions that we'd faced throughout the last year. I think the paper provides an overview of both the work of the ICB people team, but also some of the work that we've done across the whole system. I appreciate it's a really long paper, but I think that's indicative of the scale of the agenda that impacts on our workforce at the moment. The report also contains a summary of our collective Cheshire and Mersey staff survey results. I think when that was requested in March, obviously we'd just seen the release of those. We're now 8 weeks away from the release of the 2024 staff survey. So a lot of work has gone on in the intervening period at trust level and also across the ICB to make sure that we've taken appropriate actions, and we've done very much that you said we did approach. But I think it's important to say as well, on the 1st of July, the ICB was 2. And you know, whilst 2 years has gone very quickly, in terms of organisational culture and getting people settled into a new organisation, that's a very short period of time. We know that the scale of the change that we faced was really unsettling for many staff. And we've worked really hard to make sure that we've created a culture, we've been clear about our values, our behaviours, and included in the pack you'll see a diagram which shows what they are. Hopefully they're really embedded now in the organisation, but it is only 2 years on, and I think we have to respect the fact it does take a long time. The report does describe the work of our staff networks. We've worked really hard with all of our staff that have got protected characteristics or have got particular issues that really interest them and impact on their ability to be able to do their job. So you'll see there we've got things like Early Careers Network, our Working Carers Network, networks for our staff who foster or adopt children. So we've tried to create the networks that are important to our staff rather than just create the ones that we think that we should be doing. And they're really, really impactful now in terms of the impact it's having in terms of our staff and making people feel valued. We have also established in the last year the People Committee. That report's currently through to the Finance and Resources Committee. We've now, I think, got into our stride in terms of what we report, and we're moving that on from it being more of a show and tell about the work that we've been doing into very much a strategic approach. So recognising all of the challenges we've got now, we can't take very short-term views in terms of our workforce. We have to have one eye on the long term. And we're talking at the moment with non-executive colleagues about where that is best placed in terms of getting the right amount of focus and attention. And perhaps finance isn't the place for that at this point. In paragraph 6.45, you'll see the ICB equality objectives and our priorities for 22 through to 26. I think we're making some good progress around that. We have a very small team that look at equality and diversity, and what we're trying to do is make that everybody's agenda. So the same sort of approach that we've adopted when we work with our system, we work with and through, rather than trying to do things to each other. But you'll be seeing some of the work we've been doing around accreditations for Navajo, our disability confident accreditation, as well as some of the work that we do with our place directors, and Carl's previously reported about some of the work we do around veterans and military families. But it's important to stress that the ICB people function also has a system-wide responsibility. And as you know, in NHS Cheshire and Merseyside, we've got over 87,000 staff who work in our trusts in primary care. They're made up of a range of things like substantive staff, bank staff, agency staff. And in the past year, we collectively achieved the national target of our agency staff not exceeding 3.7% of the pay bill. It's been reported through our Director of Nursing and Care the impact of having high levels of agency staff has on care, and we're delighted that trusts have been really working proactively to move staff into bank and substantive posts. From July this year, we also are pleased to say that none of our trusts are using off-framework agency staff, which I think is a real credit to them. Last summer, you'll recall that we reported on the publication of the long-term workforce plan, and then things went relatively quiet, and we're really looking forward in the next few months to the relaunch of that. It comes, I think, at a really good time. Last week, we saw the launch of the social care workforce plan, which has got real sort of synergy with the long-term NHS plan. We've worked really hard in terms of the people promises, and we have 7 exemplar sites across Cheshire and Merseyside that were looking at the retention of our staff. We've seen some real positive results there, with retention going up. Our turnovers are started to reduce now. We're at about 11%. This time last year, we're at about 13.5%. So we're seeing some really good work on there. You'll see in the report as well work we've been doing about scaling people's services, so picking up very much on the work that Anne and Joe were describing earlier about how we can work collaboratively, whether or not we need 16 contracts to do the same thing or 16 different approaches. So the work of that group is really being led now by the HR directors. And finally, I just wanted to draw your attention to the detail report at the end, which looks at the 7 people promise themes, looks at how all of our individual trusts did in terms of that staff survey. Our most improved services across the whole of Cheshire and Mersey, where we are always learning, we are recognised and rewarded, and the morale of our staff. Liverpool Heart and Chest Hospital again scored highest across all 8 themes when benchmarked with its peer groups. But as I say, we're now 8 weeks away from the next staff survey, so a lot of work going on in terms of preparing for that. But I'll stop there, Chair. I'm conscious of time, but I'm happy to take any questions.
Thanks, Chris. Any questions or comments? No. Erica?
Chris, really, on the voice at 6.8 as freedom to speak up, Ned lead, that's really good to see. I was just wondering if there was anything specific in the work streams from the previous staff survey that have stood out to you that have supported getting that score, and we need to continually improve that score, don't we, because it is the voice of our staff.
Yeah, so we've taken each of those themes and we've had a work group looking at them. I think we have a voice has been really difficult for us because it's been quite complicated what routes people take. I think the appointment of Timothea Roberts as our Freedom to Speak Up Guardian, there's a phenomenal amount of work going out, talking to groups, going out into primary care. We're starting to see some real benefits there, even if it's just the fact that we have more freedom to speak up concerns are being raised, which I think is really positive. We've just about to produce some short clips for each of our people promises showing what we've done in the last year and sort of really addressing staff concerns. But I think the important bit is this isn't a people function. This is about our staff, and the Staff Engagement Forum have really worked hard to do this.
Thanks, Eric. Chris, just a comment from me, and it's reinforcing, I think, the essence of the comment in your report, and that's the disappointment I feel with the percentage of our staff within the ICB who are from a BAME background, which has been decreasing. It's below the percentage that's in the general population and markedly below the 22% average that's in the NHS. Just some comments on.
I think it's really difficult. We obviously, when the ICB was established, we were advised to lift and shift staff into the organisation. It's not our term, but what we inherited was not a very diverse workforce. We have worked hard. We've got some teams where there's a huge amount of diversity, but they're small numbers in small teams. The fact we're having to review things like our vacancies, our recruitment processes makes that increasingly difficult. And therefore it is something that we need to look at across the whole system. But yeah, it's going to be a continuing challenge for us.
Thanks. Hilary?
Yeah, on the BAME or global majority, I'll use that term today because I always use it. That point, but I think secondly, I think it's great we're going for the Bronze Award for the North West Anti-Racism Strategy, and it's great, Graham, that you're the sponsor for that. That's fantastic. I'd really like to see more visibility around our board level objectives in that regard, so we get more of a strategic objective for EDI. Anti-racism features more in our strategic plans. I think that's number one. And I think number two, I think we should become more excited about really spotting and protecting talent of our global majority and make more effort to do that. And I think particularly in times of austerity, when we are freezing posts or reducing posts, research tells us that it's our global majority colleagues who are most disadvantaged. So there's something about, and I don't know the answer, how do we protect and still nurture the talent of our global majority colleagues, be it through whatever stretch assignments or whatever? How do we make that more intentional than what it appears now in our plans? But thank you, Chris, for a good report. You've done lots of work in your team.
Chris, I think I see you nodding to those points in agreement. And Ellen?
I don't know if this is a useful point, but we, the VS6, met with Alison Navarro from the Racial Equality Hub in the City region, and she was really helpful with us in terms of developing some of those links. And I think particularly at that business and at that trustee level, I think her work is going to be very useful into the future. So gathering that partnership at this moment might be a really good time to jump into that.
We are part of that group now, so Thomasina Affle has been sitting on that group on our behalf.
Thank you. And Chris, just a final comment from me, and it's just linking the anchor institution strategy work that we've got to this discussion about inclusive workforce. We can see through that work, and we had a panel yesterday with Luft. You can see through that work that some of our trusts are making remarkable improvements around recruiting from the most deprived areas in Cheshire and Merseyside, and Luft is now up to 34% of its staff recruited from those most deprived areas, which is a great result. So somehow if we could bring some of that information into this report, it would be really useful. Okay, so this is here for assurance. People made comment, and we'll have that assurance at the appropriate level. Last couple of things, I promise. Minutes of the meetings, are they looking for any corrections for accuracies or sense? Otherwise, I'm going to seek your approval for the minutes of last meeting. Yes, can I see a formal approval yet? So we see some nods. Thank you. And the board's action log is there for us to consider. Are there any updates or comments that you wish to make? Thank you. I haven't got any closing remarks for the meeting, so thank you very much. We close the public meeting here now. I know it's been a long meeting, but it's been really productive, and thank you for your contributions.